Good morning. I am reconvening this hearing for the FY23 Performance Oversight of the Department of Behavioral Health. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, January 31st. The time is 9:33 a.m. This morning, we will hear, on Monday, we heard from the public witnesses around testimony on the performance of the Department of Behavioral Health. And today we will hear from Dr. Barbara Bazaron, who's the director of the Department of Behavioral Health, as well as her team. As I mentioned before, but for those who may just be joining us today, the Department of Behavioral Health, often referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and with adults and with mental health or substance abuse disorders, including emergency psychiatric care, and community-based outpatient and residential services. DBH serves eligible adults, children, and youth, along with their families, through a network of community-based providers and government services. DBH manages the school-based mental health, behavioral health program, and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. DBH serves district residents based on the belief that they can recover from mental and substance abuse disorders and live healthy, happy, and successful lives. On Monday, we heard from nearly 50 public witnesses, including students, community-based providers, and contractors, interested community members, as well as advocates. And they spoke on a range of issues, including the opioid crisis, the urgent need for more clinicians and behavioral health staff, youth stress and trauma, and the need for increased accessibility to DBH programs and services. We have been joined by Councilmember Zachary Parker, who is a member of this committee, and I will turn to him for an opening statement. Councilmember Parker.
Thank you, Chairperson Henderson. Suffice it to say, behavioral health and issues, especially involving our youth, are top of mind for many in the city. We heard a number of concerns from public witnesses, and I look forward to following up with Dr. Bazaron on them, as well as the status of several contracts that were secured by this committee, to just see what the status is, and wanting to highlight how are we coordinating across our system to meet the mental health and behavioral health needs of the city. So those are areas I will be focusing on, and I look forward to delving in. I do want to acknowledge the Department of Behavioral Health's partnership in Ward 5 in particular, following several incidents of violence involving individuals suffering from mental illness, and just acknowledge that they're, as well as the agency's participation in a pilot program that we're running along North Capitol to address some of the root causes of drug addiction and violence that we're seeing there. So I highlight those two instances to say I've seen the agency work on the ground, but it's clear from what we heard from public witnesses that there is more that is needed to ensure that residents across the city feel the support and power of this agency. So looking forward to digging in, and Chairperson, I'll turn it back over to you.
Great. Thank you, Councilmember Parker. We've also been joined by Councilmember Nadeau, who's joining us virtually. Councilmember Nadeau, if you have an opening statement.
Thank you very much, Madam Chair. I'm thrilled to join you today for the Department of Behavioral Health Performance Oversight hearing, because there are so many programs DBH oversees that have an impact on the quality of life for our residents. In particular, I look forward to hearing more about any staffing challenges they have and how they're standing up programs like our harm reduction, street outreach programs, the grants that you and I funded in this fiscal year, and how they're supporting those, the work of the CRT and how they're doing with recruitment, and also updates on the Sobering Center in Columbia Heights. I look forward to getting not a 30,000-foot view today, but really a boots on the ground view about how DBH is working hard to address the needs of our community, especially those most vulnerable residents who are experiencing substance use disorder. Thank you, Madam Chair, for convening us today. I look forward to participating in today's hearing.
Thank you, Councilmember Nadeau. I don't see any other members, but of course we'll turn to them as they join. Dr. Bazaron, before you begin, I would ask that you or anyone on your team who might speak today need to swear you in under oath. So if you could raise your right hand. Great. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. When you're ready.
Okay. Good morning, Chairperson Henderson, committee members, and council staff. I am Dr. Barbara J. Bazron, Director of the Department of Behavioral Health. Thank you for the opportunity to discuss DBH's performance in fiscal year 2023 and to date in fiscal year 2024. Under the leadership of Mayor Bowser, DBH supports healthier, stronger communities by working to prevent the onset of mental health and substance use disorders and by providing a range of community-based treatment services and recovery supports. DBH also provides crisis services, operates adult and child urgent care clinics, and manages St. Elizabeth's Hospital, the district's inpatient hospital. Through Mayor Bowser's continued investments, supported by the council, DBH is transforming the public behavioral healthcare system to provide whole person, culturally competent care for those who rely on it while working to improve population behavioral health outcomes and advancing health equity. The pandemic had an irreversible impact on the public perception of behavioral health care, with less stigma attached to mental illness and more understanding that addiction is a disease, not an individual failure. This openness and awareness have encouraged people to reach out for the support when they need it. I am proud to report that DBH and our provider partners are meeting the increased demand among district residents. In FY23, about 45,500 residents received treatment and support services, a 42% increase since pre-pandemic FY19. Services were delivered in a hybrid model with nearly half through telehealth. This was not the case with substance use disorders. The number of people receiving substance use disorders treatment services decreased by 23%, with the biggest drop during the first 2 years of the pandemic. Several factors accounted for the decline. The service delivery model does not adapt well to telehealth, and the disruptions in treatment regimens and social isolations are known triggers for substance use. We began getting closer to pre-pandemic levels in FY23. It is encouraging that 3,450 individuals in FY23 received medication-assisted treatment for opioid use disorders from DBH providers and in primary care settings. I also want to report that St. Elizabeth's Hospital is using a staged approach to return to pre-pandemic capacity while maintaining appropriate infection control practices. We are meeting this increased demand at the same time as we continue to transform behavioral health care and prepare to integrate services into managed care. I'd now like to update the committee on our progress. In our response to the committee's pre-hearing questions, we provided a comprehensive report on our performance. DBH and the Department of Healthcare Finance are on schedule to fully integrate behavioral health services into the district's Medicaid managed care program on April 1st. Service integration is the next step in the transformation process that began with the approval of the 1115 waiver effective January 1 of 2020. We are working in close partnership with DHCF to ensure that the integration is seamless for DBH consumers and clients and that providers are ready to operate in a managed care environment. To ensure continuity of care, DHCF has established a bridge policy which requires that during an 18-month transition period, the MCOs must include all DBH certified providers who are credentialed in their network. Along with DHCF, we have been holding public forums since November of 2022 to share specific information regarding the transition. In addition, 2 websites were developed to make information on the transition publicly available. We are planning targeted public forums and outreach for consumers to assure them that they can continue with their same behavioral health care provider and have better coordination between their healthcare providers. Residents who get services through DBH already are enrolled in one of the managed care plans for their primary care. The foundation for whole person care is timely access to both physical and behavioral health care data. As previously reported to the committee, we have provided financial and technical support for providers over the past 2 years to improve service delivery and adopt new business processes to operate successfully in a managed care environment. In addition, we are targeting support to providers of substance use disorder services with extensive training and technical assistance on person-centered care using nationally recognized medical necessity criteria. Our goal is to ensure clients receive the appropriate care to improve outcomes. After the integration, DBH will continue to certify providers who have obtained national accreditation for one of 3 accrediting bodies to demonstrate compliance with national quality of care standards. DBH certification is not duplicative and ensures compliance with district regulations. Currently, 96% of our providers have national accreditation and 3 have applications pending. I will now briefly update the committee on key strategic initiatives. 988 implementation. Calls to 988 Lifeline increased more than 30%, which indicates that it is easier for people to get help when they need it. We now co-locate staff at the Office of Unified Communications to support the diversion of certain 911 mental health related calls to DBH instead of an automatic law enforcement response. The CRT provides a clinical response to crisis calls and has a regular and ongoing presence in the community. DBH has partnered with MPD since 2009 to train patrol officers called crisis intervention officers to recognize the signs of behavioral health and to use the most effective de-escalation techniques. In FY22, the mayor mandated that all police officers and recruits receive mental health first aid for first responder training. Working with MPD, DBH has trained 97% of active officers either as crisis intervention officers or in mental health first aid. The pandemic exacerbated the already worsening trend in youth mental health, including children who have never previously displayed symptoms of a behavioral health disorder. DBH has identified mental health screening, evidence-based practices that support trauma care, and strengthening parent engagement and parenting skills as critical ingredients to address youth mental health. DBH supports screening during the annual school wellness checks. DBH through DC MAP offers telephone consultation to primary pediatric care providers from a team of mental health providers. The District of Columbia is the only jurisdiction in the country where elected leaders have prioritized the behavioral health of young people by funding at least 1 mental health clinician in every public school based on our research. Currently, 68% of the public schools have a clinician on site, either from a partner, CBO, or DBH, or both in some schools. School-based clinicians train students in anger management, conflict resolution, and building social and emotional skills to help them problem solve, cope with grief and loss, reduce stress, and manage their emotions, which promotes healthy decision-making. In the past year, we have focused attention on strengthening prevention activities by requiring prevention curriculums in all schools and requiring parent engagement activities to build relationships with parents. All of these strategies and services play a critical role in violence prevention. To help address the shortage of licensed mental health professionals, we have initiated 3 pilots, which I can talk about during our conversation. Since Live Long DC, the district's comprehensive plan to reduce opioid use, misuse, and related deaths was released 4 years ago. DBH and 83 community-based grantees and 15 government agencies have focused on best practices in prevention, treatment, harm reduction, and recovery supports. Through the district's combined efforts, we are making it easier to get treatment through multiple entry points that include certified community-based providers, medication-assisted treatment centers, and emergency departments in all 6 community hospitals, 8 community health clinics, primary care settings, a roving DBH mobile van, and the new DC Stabilization Center. Substance use disorder units for women and men are in use at the DC jail. Despite the urgent and growing district-wide mobilization, the Office of Chief Medical Examiners report that while the rate of the increase has slowed since 2020, the number of deaths continue to rise. What is happening to drive this increase? Fentanyl. Fentanyl is a deadly synthetic opioid and is now in 99% of overdose deaths. Our message is to expect fentanyl in all street deaths. We are doubling down on harm reduction strategies proven to save lives. DBH, along with 130 community-based organizations and government partners, distribute about 90,950 fentanyl test strips and 291,850 naloxone kits free. We are also expanding outreach to overdose survivors and targeting outreach to high-risk occupations and nightlife. Harm reduction strategies save lives. We have 8,341 reported reversals of an overdose by FEMS and community providers using naloxone. But naloxone is of no use if you are alone. In recognition that the majority of people overdose in their own home or in the homes of family and friends, our outreach teams are passing out naloxone with added messages that if you use, don't use alone. Also, we are planning a public awareness campaign aimed at young people and their families to raise awareness of fentanyl and prescription pills to prevent accidental overdoses. With Mayor Bowser's direction and investment in the support of council, we are transforming our behavioral health care in the district. Our vision is that all residents have the support they need to live healthier, longer lives. I want to conclude my testimony by expressing my appreciation for certified peer specialists, leaders of consumer and recovery groups, and peer-led centers who model our conviction that treatment works and recovery is possible for everyone. Thank you, Chair Henderson, for your commitment to the well-being of all district residents. I look forward to our continued work together, and I and my team are ready for any questions.
Thank you, Dr. Bazaran, and thank you to your team. I would say for the public, as Dr. Bazaran mentioned in her testimony, we send a litany of questions in December, and those pre-hearing responses can be found on the DC Council website, and we'll be referencing those throughout the hearing today. We're going to do 12-minute rounds. That's good. Cool, great. And let's see where we go from there. Okay, I want to start with grants, but not the grants that perhaps Councilmember Nadeau and Councilmember Parker are going to bring up. I want to talk about the other type of grant activity work that you all do, because when I look at the Department of Behavioral Health, a lot of your activity, a lot of your work is around granting to other organizations, nonprofit groups, contracts that you have. But the grants that you receive from federal government and other entities, you are the conduit for that getting out into the community. And upon examining the grant spreadsheet that you all submitted in your pre-hearing responses, I've observed a significant amount of underspending. And sort of not thinking about, is this a one-time thing? And because we've been asking, the council asks these questions every year, I've gone back to look at last year and the year before when I was a member of this committee to see what those rates were. And it was a continuation of some things. In FY23, you all had an approved budget authority for grants of about $56.7 million. And then you had expenditures totaling about $36.7 million. Now, obviously, I recognize that there are some grants that are multi-year grants. You have the ability to carry over, but that's about a third of your budget authority. And so when I hear, I got 50 public witnesses who are telling me we need more, and then I look at the budget of the agency and know that while there might be some restrictions on some grants, you all have funding available, it is a bit of a concern to me. So a particular concern is that we have about $9.5 million attributed to state opioid response grants alone. And given our issues in terms of opioids in the district, I want to ask some questions here. So what is the specific challenge or bottleneck as it pertains to getting funding out the door for the state opioid response grants?
I think there are a couple of things. One is that we do follow all of the district's procurement regulations as required by law. And so we do, in fact, prepare the solicitations. Once we have budget authority, then we're able to move those funds out into the community, and we do that as quickly as possible. So that's on getting it out. The other thing that happens is once a provider receives it, in some instances, there is underfunding by the providers for a variety of reasons, and we do provide the opportunity for carryover funds with the approval of SAMHSA.
Okay. Well, in some of the other grants that we have, I noticed that DBH is very reluctant, if at all, to put a grantee on a corrective action plan after they notice that funds have not been spent. So why don't we go down the line and talk about a couple of them? So There is a block grant for community mental health services. This was an ARPA grant. Now,
Mhm.
I know ARPA money goes away, and I don't like to give the federal government their money back, especially since they owe us for some other things, but we received $2.9 million in approved budget authority for this ARPA grant to provide supports to address the COVID-19 pandemic for Americans with mental illness. I have here that in FY '23, we spent 175,000 of that.
Mhm.
What happened?
Mr. Neff, who is responsible for our grants management, will speak to that.
For that one in particular.
If you just turn your mic on. There you go.
Sorry. For that one in particular, our spending authority, budget authority, and having that grant loaded was delayed. And when that happens, we follow, as Dr. Bazran mentioned, all of the same procedures, notice of funding availability and then the process. But we got the funds out the door several months late in that situation.
Okay, so when you say the funds were loaded late, which agency should I talk to about that?
Well,
Is that a CFO problem?
it is that, but it's interesting. We receive federal money, and then depending on how we receive it, it sometimes then requires additional approval to be loaded and spending authority. So it goes through several layers of approval before we get the funding approved in our budget to spend.
Okay, but who?
Well, in certain cases.
And I'm asking, we're in the middle of performance oversight. So if it's not your fault, say that. And I'll have a
Oh.
conversation with the agency for whom is
Okay.
causing this
Well,
backlog or try to get to the bottom of what the issue is and how we can be more streamlined here.
Mhm.
I recognize you guys don't have procurement authority. So
Correct.
if I got it, but you're not telling me who or
Okay.
not person, but
Well-
like which agency is the issue?
It's hard to exactly pinpoint, but I would say from my looking from the outside in, that when the control board was set up, and there are many layers of approval required, that even though we have notification from federal entities that we.
You're not
have
going
the
to tell me which
funds-
agency to talk to?
Yeah, that one is OCFO.
Okay.
And then in addition, because of how it might be loaded, and if it's over $1 million, it's the council who has to then approve it yet again so that we have ability to spend it. So if that could be improved, that would be great.
Okay. There's a grant that was promoting resiliency and recovery. It was an emergency grant to address mental health and substance use disorders during COVID-19. We got, you all had a budget authority in FY '23 for 515,000, and I have here that there were no expenditures in FY '23.
We'll follow up on that.
This is
Dr.
question
Weber.
16, an attachment that you all submitted.
We'll follow up on
I'm
that.
reading from the spreadsheet,
Mhm.
okay? We heard a number of folks testify about the Access Helpline on Monday. And what I found interesting is that we received grant dollars for the Access Helpline. I have here for FY '23, we had $359,000 that was set aside to help the Access Helpline become fully staffed with licensed clinical professionals that will respond and provide clinical expertise to calls received through 988.
Mhm.
We did not spend any of that money.
Mhm. We are currently in the process of recruiting, and as you know, it's been difficult to recruit clinicians within the district so that we can provide those services and supports, not only within the Access Helpline, but also within our community response team and our school-based behavioral health care team. And so we know it's been very difficult to do that.
Okay, so let's talk a little bit about the Access Helpline since we started on that conversation. My understanding is that traditionally the Access Helpline was used as a opportunity to help folks navigate where they need
Mhm.
support. But the DBH responses indicate that you all have shifted an overall focus towards um, crisis and suicide response and support. What led to this change?
Well, first of all, I think I want to first of all clarify the fact that in terms, if somebody calls Access Helpline, if they call 1-887 We Help, they will still get the navigation services that they have always gotten. That has not changed.
So I mean,
That has not changed.
well, PDS had representatives
I
who said
understand
you
that.
get a list now as opposed to
Mhm.
someone helping to set up appointments.
Yeah, that if PDS calls, then, and that's happened, then that would be something that would be outside of the process that we've laid down. So I want to talk about that first.
Okay.
And make it clear that if somebody calls Access Helpline, they will get a live person, and that person will help them in terms of connecting them to services and ensuring that they get there. They can do it that way. Or if they choose not to do that, we have expanded the way in which you can access care. They can also send an email if they choose to do that. And also, every day, we look at those frequently throughout the day, and we make that connection with the providers so that people can get the care that they need. So that's one piece. The other piece is around the 988 process. Um, Access Helpline has been our lifeline and has been certified as our lifeline for many years, from when I was here before. And what we are doing as the federal government has now indicated that 988 should be the only number that we use, and they want to move and migrate to that. We have moved to kind of beef up that support and service within the Access Helpline, understanding that a lot of the administrative functions that we currently implement right now are going to move to the MCOs as a part of the transition.
So
Their
the MCOs will take on the
They're going to
access.
take on member services. That's a part of their contract responsibility. And so what will happen if somebody calls and let's say they don't know who their MCO is, then we will be able to help them identify their MCO and make that warm connection to the MCO. And so we put some things in place so that people don't fall through the cracks.
Mhm.
And I don't know if Dr. Bebo.
Dr. Bazaran, are you not all concerned that now that's a two layers now that someone would have to go through, right? I call the Access Helpline because I need support.
Right.
And then your question would be, well, who's your MCO provider? And we can connect you to them.
The question is, okay, do you know who your MCO provider happens to be? And they say, well, no. So we can look in the system and identify that, and then we can make that contact with them to the MCO membership, you know.
But do you see how that could be perhaps off-putting to someone that I called a number and they're just passing me on to another person?
Well, we're not really passing them on. Remember, we are going through a transition where we are actually at the point of doing a full carve-in to manage care. And so what that means is the MCOs will be responsible for both the physical health care as well as the behavioral health care of an individual so that we can really achieve whole person care.
I understand, but if I'm calling it an emergency,
If you're calling in an emergency, we will respond
Okay.
to that emergency. That does not go away.
is the Access Helpline team and the folks who work on 998 the same team?
Yes.
Okay,
Dr. Bebout, did you want to add?
got it. If you just introduce
He's
yourself. for the
Dr.
record.
Richard Bebout, and he is our Chief of Crisis Services responsible for Access Helpline.
Good morning, and thank you for the opportunity to respond to this question. A couple of phrases are ringing in my ears from Monday, one being the characterization of Access Helpline being gutted, which is simply not the case. Access Helpline is continuing to staff up although we do have vacancies, we're all familiar with the staffing challenges, and these are overnight and weekend positions as well. We did begin to transition in response to more than a 30% increase in 988 Lifeline calls that we observed in the first year after the 3-digit code went live. To move gradually out of the navigation business, but we are not out of that and won't be out of it for in the foreseeable future. The other phrase that has been ringing in my ears is the idea of no wrong door, which is exactly what we are pursuing. The dominant way that people enter care is to walk in the door of the provider that is in their neighborhood or that their friend has recommended to them. We don't want to require them to go back out in order to come in the same way that we decentralized access through the ARC. We want people to be able to access and get enrolled in services through, as you said, no wrong door. They should be able to go through any door. There are alternatives that we have created because a huge percentage of the call activity at Access Helpline has historically been individuals seeking to transfer from one core service agency to another. The creation of an additional administrative phone line and an email box for people to do that rather than having to wait for a live call taker to facilitate that was an additional option. As Dr. Bazaran said, if you call 888-7-WE-HELP, you will get a live call taker and they will facilitate the same linkage that they have always.
Okay.
Going forward with the MCO carve-in, the member services responsibility and the network maintenance and so forth will transition to the plans, but in July this year or July next year, if somebody calls that 888 Access Helpline number, we're still going to respond and still assist them in navigating to where they need to be.
Okay.
The emergency calls are exactly what we're trying to prioritize. The last question that you asked about if somebody's calling, with urgency or emergent concerns, we're going to respond the same way we do now to try to resolve that telephonically, to deploy a mobile crisis response if that is indicated, to do whatever and to link them to whatever appropriate follow-along services they need.
Okay. I'm over my time. I have more questions. Now I have questions about the staffing and, some other pieces around Access Helpline, but I'm trying to model good behavior. So Ashley, if you could put 15 minutes on the clock and Councilmember Parker, when you're ready.
All right, I'm going to start with contracts. And last year, the committee secured several contracts, including some $250,000 for opioid abatement services for the Ivy City and Trinidad communities in Ward 5 along Mount Olivet Road. What is the status of these contracts? And can you speak to why it has taken so long to get the money out the door?
The contracts for the targeted substance use
Yes.
outreach have been.
And I'm saying contracts, I perhaps should say grants.
You're
The
correct.
grant funding that the committee secured, what's the status and why has it taken so long to get it out?
Those grants have been awarded, although we did not pursue a competitive process. We did have to follow the procurement process. We made those awards in December. I'm sorry, we released the solicitation in December. They were awarded on January 3rd. Since that time, the 4 awardees have taken varying lengths of time to respond to deficiencies or provide additional documentation or to revise budgets. But all of those have been signed and have moved to our fiscal division and Codes have been created and they are moving.
And how long before we can see services on the ground?
As soon as they can staff. And we know that one of the grantees, in terms of the way they plan to do this, they already have
Mhm.
actually several of the grantees already have staff that have been identified to do this so they can begin immediately.
Following up
This
there.
one, I mean, well,
This,
today's
okay,
the
yeah, I need,
31st.
so
February for
sometime
sure.
in February, we should expect that services
Correct.
will begin on the ground. I
Correct.
also know there were services secured for Ward 1. I imagine my colleague will follow up on that. But that is
Mhm.
great news. What took so long? Why did it take a year for us to get that grant money out the door at a time when we're acknowledging we have an opioid crisis?
The funding was one-time funding in this fiscal year budget,
Yes.
October 1st. So it took 3 months for us to make the awards.
3 months, yes, from the beginning of this fiscal year. But we still, I'm taking your word that they're gonna begin sometime soon, but
Mhm.
you had a runway knowing that the grant money was secured. It just begs the question, why weren't we ready to execute on them by the end of October?
Again, I can't really speak to all of
Okay.
the particulars.
I want to stay on contracts. We heard concerns for processes around contracts in general. Someone testified on Monday about slow payment and or what they framed as punitive treatment, that if there were criticisms against the agency, then their contract was revisited or payment was slow. And in fact, they said they were still owed some $75,000. I'm not going to get into the specifics here, but I'm happy to follow up with you offline. But two things that raise for me are all contract negotiations and dealings in writing
Mhm.
with the
Yes.
agency. This individual framed that they never put anything in writing. I get a phone call and I'm told there's a delay in payment or process, and it's because of X, Y, and Z. So you're saying that that is not a practice, that all
That's right.
contractual dealings are in writing. And should we want to follow up, who would be best suited at the agency to talk?
Mr. Neff would be the person to follow up with.
Okay, I will follow up
Mhm.
with you on that. Given the amount of the contract and the delay and how this person was framing it, that it is causing strain on their business, it was a concern. So I will follow up on that. We also,
And I can also, I know, I listened also to all of the testimony. And the other thing I think is that if there is an issue with whether or not, for example, that particular contract was related to store money coming down.
yes,
And we have to follow the federal guidelines. If what they have submitted, like, let's say for a budget, is outside of that,
yes,
then it will take time for us to get through that process. And so it really is a joint process that
understood.
requires.
Frankly, how they
yes.
framed it is that the
Mhm.
agency slow walk, stalls, asks for repeated revisions in an effort to get back at someone that maybe
No, that's
is
not true.
leveraging a criticism.
That is not true.
Okay, so I will follow up
Yes.
offline. I want to talk about ACT services. We heard that since Mr. Wooden's passing in the agency in July of 2022, I believe,
Mhm.
that his role was vacant. Can you state for the record the role and the title that Mr. Wooden had at the agency and what efforts, if any, have been made to fill that vacancy?
Yes, certainly. First of all, I can tell you that, I worked with Mr. Wooten for many, many years. And so he was really a dear colleague of mine. And he worked very hard to really develop the ACT services. And so I do want to say that in advance. However, I do want to also indicate that when, with the passing of Mr. Wooten, we as he vacated that position, we did put an interim person in that role. And so that role has never been vacant.
So are you suggesting there's an interim person now?
There is an interim person now, and I need, Annette, Annette is her name.
What's the name?
Good
Uh,
morning, council
Annette,
members.
Go ahead.
Yes.
Good
Mhm.
morning. I'm Jean Moise, Deputy Director of Adult Services,
Mhm.
and that area reports to me. So I thought I'd
Yes.
come and sort of answer your questions directly. Upon Mr. Wooden's death, we immediately put in that position on an interim
Mhm.
basis Annette Lee, a senior supervisor
I just
reporting.
want to make sure I'm,
Annette
Annette Lee.
Annette Lee.
Annette Lee.
Got it.
Supervisor who reports to a director who reports to me, that she reports to the Director of Integrated Care Division and the Integrated Care Coordination Division. And because ACT is part of that continuum of services, it just made sense that Annette, who's supervising the ICC Integrated Care Coordination Team, assumes that role. At the same time, so it was never unfilled, vacant,
Understood.
unattended. At
And
the same time,
Yeah.
we implemented a process and informed all the providers of a new process to make referrals and receive authorizations for ACT. We established a mailbox, an ACT mailbox, and it's.
And that was
ACT
going to be
is-
my next question, because we heard complaints that there are several emails that are sent that never get responded to.
Well, the address is ACTACT@dc.gov.
I don't doubt that there's a
There are no,
mailbox.
there are no, from our perspective, there are no emails that are unattended. Annette Lee has two other staff that track and monitor that mailbox regularly. And to my knowledge, and based on our data, every email that we received is responded to within 24 hours. So you can.
We will follow up, and this isn't to cast blame, but we
Sure.
just want to make sure
Sure.
if people are reaching out for care and support that they
We have a
actually.
process.
I
And-
get it. I'm
Absolutely.
glad to hear that there's an interim position. Another concern around ACT services was, as we're moving towards April 1 and the transition, there's a
Mhm.
lack of clarity around these services. Can you give us a sense of how are you accounting for the transition, ACT services, that interim role?
We can both speak to this.
Yeah.
First of all, thank you for that question. We worked very closely with our partner, the Department of Healthcare Finance, as we did two things. One, we reviewed the rate that was, and the rate process by which people got paid, which was really important to go from like this 15-minute unit to a daily rate. And then in addition to that, and a monthly rate, and in addition to that, we also looked at the process that we were using, the model that we were using, and wanted to make sure. Thank you. And wanted to make sure that in fact, we were providing the highest quality of care available for these individuals who have multiple needs. And so we worked very closely, both Director Byrd and I met individually. We worked very closely with our provider network as we began to look at how we were going to change this model of care. We adopted the TMAC model, which is a high quality ACT model. We provided training through the University of North Carolina to our providers to get them prepared. We engaged in fidelity checks to see how things were going. And then the other thing that we really addressed was the financial aspect of the model. Within the TMAC, there are requirements for 8 contacts a month with the individual. And looking at those, 3 of them can be virtual, 5 of them need to be in person. And as we taught, and there are also staffing requirements. So as we met with the providers said, listen, it's going to take us a little time to kind of get up to speed so that we can reach full fidelity of this model. And we are concerned about whether or not fiscally we're going to be able to do that.
On that point about the transition, we also heard concern for community support workers, and there's a lack of both education and payment systems for them.
Mhm.
And that folk have heard from the agency that sometime after April 1, the agency will deal with community support workers.
No, I'd like to, if I can put this over here for just 1 second around
Yes.
community support workers. First of all, the question was whether or not we were going to change the rate or the process or the requirements for community support workers as a part of this broader rate
Yes.
study. What Director Byrd and I have communicated clearly to the providers on multiple occasions is that we are not changing community support at this time. Starting in July, we're going to have conversations with the providers regarding what that needs to look like as we move forward.
And so what happens between April and
It's
July?
the same as it's always been.
How
Community
do-
support is not changing.
But how do we
Community
account?
support will be billable like
But
it
the
is right
specific
now.
concern is around both education for providers, but also how providers and others are billing in their systems.
Mhm.
And it seems like you are of the mind, the status quo will maintain through July, but it seems like providers and advocates are saying we don't have that same level of
And then the other
certainty.
thing I would like to say is that we've done significant training around billing for providers through the revenue cycle management model and other trainings, both individually as well as in
And
groups.
you've done that training specifically related to community support
It's
workers?
related to all of the services that are being delivered to make sure that providers know how to bill for services.
Well, I want to come back to this. A request I would make on behalf of the committee is that but before April 1, not
Mhm.
July, before April 1, if there could be explicit communication to providers related to community support workers, it's clear there's a disconnect from your interpretation and your sense of what's happening and what we heard. And I'm not confident that people may wake up and realize that they are disconnected or don't have the know-how and or payments aren't being made or what have you. So happy to follow up on that. I did want to also come to the Opioid Abatement Advisory Commission in the last minute, and maybe I should hold off on this to the next. Actually, I am going to hold off. Let's talk about transition support at DC Jail.
I'm sorry, say it again, please.
Transition support at DC Jail. It is my understanding that there was a contract that ended in July 2022. I believe Community Connections used to be the service provider. Since the ending of that contract, can you give an update of how you've either tried to renew that contract or replace transition services at DC Jail for folk that are returning?
First of all, that was not a DBH contract.
That was not.
That was not a DBH contract. That's number one. But secondly, I do want to talk
So
about,
whose contract was that?
I believe it was,
Office of Victim
Victim
Services and
Services
Justice Grant,
contract.
OVSJG.
mhm.
And did DBH have anything to do with that contract?
No, but we do provide services.
So you're currently providing services?
Yes.
Transition support services?
Yes, we do provide transition support services. We work with the Ready Center. We do in-reach to individuals who are in the jail. The pre-release services identify those people who are going to be released within the next 30 days. We contact and touch about 100 people a month, and that's under Dr. Chad Telbrook, who's here with us today. And we offer behavioral health services, and then we
Okay.
connect to services.
I'll pick up there in my next round. I'm out of time, and I just want to
Mhm.
respect the clock. But thank you.
Thank you, Councilmember Parker. Councilmember Nadeau.
Thank you, Madam Chair. Thanks, colleagues. Glad to be here with you, Dr. Bazran. And I want to thank you and your team for working so closely with me on ensuring that our community navigator grants could get out the door to ensure no interruption of services in Columbia Heights and Ward 1. So thank you for that. I know that it was sort of unusual, but given that we were transferring the existing grant from one agency to another, I was very pleased to see the way it all came together. So thank you for that. As you and Councilmember Parker discussed, the awards for the substance use disorder and behavioral health targeted outreach pilot have been awarded, and outreach will likely begin in February. So in Ward 1, we have District Bridges, working all across the ward, and we have HIPS working on T Street. There are a lot of data collection and tracking requirements under the grant. How will DBH use this data to inform future grants or other programs?
Oh, first of all, one of the things that's helpful for us in terms of tracking the data is, do we need to, for example, target a different area? Do we need to have more resources in a particular area? Are the needs different than what we anticipated? What are we hearing from the people who are receiving those outreach services? And so how do we really need to modify to make sure we meet the needs of the individuals who are there?
Fantastic. And this model that we are advancing is a place-based model. It's a little different than what the community response team does because of course they have to stretch all across the city 24 hours a day.
Mhm,
But it is meant to augment it. How does the CRT work together with organizations on the ground doing this type of work?
mhm. Um, Dr. Bebout, do you want to?
Yes, good morning, council member.
Good
As you
morning.
know, CRT has worked very closely with District Bridges in Columbia Heights at Civic Plaza. We continue to work with other SOAR-funded outreach efforts across the district, including the other targeted areas that have been the subject of these awards. Again, as you also know, the community response team, although we do systematic outreach to hotspots as much as possible, our primary function is responding to crisis calls. So
That's
that
right.
is the priority for the CRT team. But as you know, we assigned a bilingual staff member from CRT to do enhanced outreach at Civic Plaza in Ward 1. And similar kinds of efforts will be made to coordinate and augment the targeted outreach grants as well as the existing safe syringe and other harm reduction efforts.
I appreciate that very much. And while I have you, let me ask, I know that CRT has seen a significant uptick in crisis calls. I believe it's 37% from this time last year. How is it going with staffing and recruitment? I know that's been a challenge. And how can we support that effort?
Thank you for the question. It is a challenge. We have made significant progress. We now are up to 22 call takers in Access Helpline, including 5 who are co-located at the Office of Unified Communications in support of our 911 diversion program. CRT, last I saw, was at 48. Continuing, we have the positions in recruitment. As we
I'm sorry,
move
is it about 20 positions in recruitment?
18, I believe.
Okay, great. Carry on.
If I can just comment in terms of the difficulty, there was a witness on Monday who is a CRT team member who really spoke, I think, appropriately to the range of difficult and sometimes dangerous situations that those team members are exposed to on a daily basis. So as we continue to build the team, we are also working very hard to provide staff supports, debriefing opportunities. We're working with a national expert in trauma-informed care so that so that we take care of our workers. It's also very much a part of why we are being very deliberate about our expansion of eligible call types for 911 behavioral health diversion. And as we move forward, we look forward also to talking about the work that we're doing with MPD to develop a co-response, and as was already mentioned, to achieve almost universal training in mental health first aid and crisis intervention officer training with our law enforcement partners who are critical to the work we do.
I'm glad you mentioned co-response because I actually did have another question for you all related. In the secure DC proposal that's before the council right now, there is an opportunity for MPD to declare drug-free zones for 5 days. And of course, the concern of those of us doing the work on co-response on substance use disorder, outreach, et cetera, want to know how DBH is being engaged on that. I'd like to know if you have been at all, and if you're able to work through opportunities there so that MPD is engaging with you. My concern is that the declaration of the drug-free zone could cut off services to those that we've been trying to reach in those areas.
Councilmember Nadeau, I can speak to that.
Fantastic.
I have certainly, we work very, very closely with the chief. I personally work closely with the chief. And she and I will continue to work closely in terms of how that particular activity is implemented and the implications on service delivery. She and I will continue that process.
Thank you. I raised it with her too as a concern. I certainly want them to be able to address the sale and trafficking of drugs in our communities. I know that's been a huge problem for many of us, but we are making major investments in the human beings there who are suffering from substance use disorder as well, and I don't want to lose that progress. So thank you for doing that work, and I'd be glad to stay apprised of it. I wanted to also ask you about the Ward 1 Sobering and Stabilization Center. You did give some good responses in the pre-hearing. Thank you. You noted that the RFP will be released this month. Of course, today's the last day of the month. Can you give us an update on that RFP?
My understanding is that RFP will be released very shortly. I believe it's within the week of the 5th of February. Right.
And it's managed by, not DBH, but
DGS.
DOB or
Mhm.
DGS, I'm
DBS.
sorry, DGS.
The Department
The
of Buildings,
RFP will be through DGS,
through the Department of Buildings. Right.
Department of General Services. Okay, and then do you
DGS,
happen
yeah.
do you happen to know how long it'll be open, the RFP?
I don't know.
Okay, I will ask them. So what will DBH's role be with the selection process and the next steps?
Once we get to the process where we need to select a vendor, we'll be very actively involved in that process. The development of the structure and the facility, we will work very closely with our partner agency around that to make sure that it is sufficient to meet the service delivery needs. But just like we did before, we'll put out an RFP for a contractor to operate the service.
So the RFP that will go out under DGS, is that simply for the build out or is that also for the provision of services?
It's for the, go ahead.
That is a design and build, will be a design and build contract. We will be on the evaluation panel for the RFP, and I'll be the representative for DBH in that process.
Is there any risk to doing an RFP that's a design build without having the community provider on board to guide the design of the center?
That is to select the architect, engineers, and contractor that will do the subcontracting. It doesn't mean that the design is completed.
Correct.
We have previously completed a fit test. So meaning with generally the space, will it be able to accommodate the program? And that was completed last year. And so that is the only thing. And so in terms of, entrances, exits, layout, we just wanted to make sure that it had sufficient amount of space. I think, one of the challenges that we'll look that's different than the first stabilization center, it's 2 floors.
Hmm.
So, because of that, you have to look at different lines of view of staff in terms of extended stay beds, and then the treatment areas, and then and additionally, security. There will be a different security model for that because there's 2 floors.
Does the RFP include information from the fit test?
I'm sorry,
Does the RFP include information from the fit test that you just mentioned?
it does.
Great. So that will be publicly posted. So for example, if the ANC wanted to review it, they could take a look and understand what was considered in the fit test.
Yes,
Okay.
that is available.
Okay. So there's great community interest in this project. As you can imagine, there is a whole range of types of interest. And one of the things that the ANC has asked if there could be a community presentation on it. At what point in the process do you think it makes sense for there to be a community presentation?
I don't know that because we're not the lead on this piece, but certainly happy to reach out to my colleague who oversees that at DGS and to ask. I believe it would be after everyone's on board in terms of who's been assigned and given the award for the design and build would be a good time to get that feedback into the process.
I agree with you, but I also think actually what's really critical is someone being able to lead a conversation about the program there. And so when do we start having that conversation both at DBH and with the public?
In terms of program opportunities, those will start fairly directly because we do want to make sure that we have input. And you and I have talked about that before as we begin to frame out the contract.
Fantastic. I would love to follow up with you, Director, about that
Certainly.
community conversation in the ANC. The ANC
Certainly.
is doing a tremendous amount of work in community trying to keep people on board, and I want to be able to support that by having you come out, you and your team come out. So thank you. We definitely want to keep the project moving forward and avoid any pitfalls in community. So I appreciate that. And I appreciate this update, and I will certainly follow up with DGS as well. Will there be a separate RFP process to select the operator?
Yes.
And when do we expect that will take place?
The RFP for the operator, when was it?
Sure. In order to make sure that we have a vendor in place, I mean, my recommendation is that we would begin that process mid-year of 25.
This year, right?
24.
Yeah.
Mhm.
Okay. Meaning begin that process, meaning scope of work, RFP release, all of
Right.
it.
Yeah,
Okay.
exactly, because we've learned a lot from the first
Right.
stabilization center, and we want to make sure that that's incorporated into the SOW.
And do you plan on using the procurement authority that DBH has under the declaration of the public emergency for the opioid crisis for this center?
My understanding is that that authority ends February 15th, and so I don't think that we'll be using that.
Thank you for that. It looks like I'm just about out of time. I may come back to you as I'm popping back and forth with the Judiciary Committee, but this has been very helpful. Thank you so much.
Thank you.
Thank you, Councilmember Nadeau. I just want to sort of pick up on something that Councilmember Nadeau mentioned. I feel like the second location for the stabilization center is very different than the first location because the first location is not in a residential area, right? It is across the street from an old church, a storage facility, and commercial buildings, et cetera, but also, you all had owned the building prior. Folks
Mhm.
were used to individuals coming in and out of that facility. I think the location in Columbia Heights is different because it's in the middle of a residential area with people living on both sides of it, even though it used to be a firehouse. And so it is a bit, I feel like in the conversation of like what comes first, the chicken or the egg, the idea that we're going to do a RFP, DGS is going to do a RFP for design build before any agency has a conversation with the community about what is to happen feels like we're doing this backwards.
Mhm.
Because I imagine that they're going to become folks who come to that ANC meeting who says, well, it doesn't matter what we think. You guys have already made up your mind because you've already put out a contract for X million dollars in order to do the design build. So I hope that, I know you said it comes out the week of February 5th. I truly hope that you all and DGS can get together and have that conversation with the community in February.
Mhm.
I've seen this happen before where folks, the community will get excised about it because they will feel like they were sort of left out of the process. On that, in the pre-hearing response, you all stated that you were considering the necessity for a third stabilization center. But even though the data clearly shows the highest number of fatal and non-fatal overdoses is in Ward 7 and 8. So what's the hesitation about a stabilization center east of the river? Or in Ward 5?
I don't know that there's hesitation about that. I would say that, we will, I look at the data at which we've been looking at and determine where a next location would go based on that.
Okay.
There's
Is
no
that
hesitation to have one in Ward 7 and 8.
okay? So that's more of a budgetary conversation, yes?
Yeah. no
Okay, great.
hesitation.
In terms of the existing stabilization center, at least everything that we've heard, things have been going well. One of the questions I have, so obviously I recognize that the stabilization center was created for adults, but have there been any youth who have presented at the center seeking care?
No, 18 and up.
18 and up.
Mhm.
Okay.
And, and we, almost 1,000 people have come through the doors of the stabilization center, which really does two things. It shows that the service is needed. It shows
Mhm.
that people really trust going there. The word is getting out, and then it gives us an opportunity to connect them to care if they're ready to make that recovery journey.
Over 1,000 people
Not
since.
over 1,000. I said almost
Oh,
1,000.
well,
964.
Okay.
I think. Mhm.
almost 1,000 people, and it's only been open since October.
It's October 31st.
Yeah, so technically November.
Mhm.
That's incredible.
It is incredible.
And I think it demonstrates the need. Well,
Yes.
obviously we have a lot of data points to sort of demonstrate the need, but I think that, yeah,
Well, I think it demonstrates the need and also the accessibility. As you know, was really a part of developing a similar center in another state where we didn't get uptick in terms of utilization for over a year.
interesting. Okay.
So we
Okay.
learned a lot from that experience
Right.
also about what we needed to do differently to enhance accessibility.
Right. And I imagine location is part of it. If we think
Location is a
about
part of it.
the K
Yes.
Street location,
Mhm.
metro accessible in a number of different
Mhm.
ways, kind of central to where
Mhm.
people have.
Been coming.
Yeah.
Mhm.
Okay. Okay. So we'll follow up during the budget. Well, I'm sure Councilmember Parker will most certainly follow up during the budget season around funding for a third center. But going back to grants for a second, in terms of as we talked about, sort of state opioid response, and even the opioid abatement commission, as I look at the amount of grant funding that we have already flowing outside of the settlements that we haven't spent, I'm concerned about us using opioid abatement settlement funds for something that could be funded with SOAR dollars,
Mhm.
but we just haven't done it yet. So how are you all navigating that in terms of the traditional things that we've been doing, whether it be additional vending machines, or, substance abuse outreach work, et cetera, that should be SOAR versus what should be, through the abatement settlement funds.
Right. Thank you for that, council member. I think you will recall that as a part of the opioid abatement commission meetings, we did present data that showed where the needs were based on our evaluation. Things that we felt still needed to be addressed. We used that assessment data to continue to build Live Long DC and to fund other activities. One of the things that came up is the need for additional vending machines. And so that's one of the things that we're working through with DC Health in terms of how that might happen. And there are other areas in which we certainly want to move. How will we, for example, expand peers and where they're located? And what will our communication strategies be that are different? And one of the things that I've said at those meetings, as well as the staff have indicated, is we don't want to use the opioid abatement fund for services and supports that could be funded through SOAR. And so we have asked the committee to look at that data and identify if there are other issues that are outside of that we could use those funds for, because as you know, there isn't a large amount of money within that fund.
Right.
But we want to make sure that we get it out quickly, and we've been trying to do that. And also that the funding is used to expand what we're doing as opposed to duplicate and
Okay.
supplant.
Has SAMHSA expressed any concern about our underspending with SOAR?
No, they have not.
They have not sent
No.
any notification to the department?
No, we're in good standing with SAMHSA. There was an issue that I inherited when I came into this office, and actually, Mr. Neff was instrumental in helping us kind of resolve that around our grant funding. So you may.
Okay.
But
Oh,
we're in
that's
good
okay.
stand- Okay, but we're in good standing.
Okay.
We have nothing.
All right. I want to ask some questions about the capital budget. Because I recall we tried to make some changes to the capital budget, and then you guys said, no, we need that money. And then it didn't get spent. So let's talk a little bit about that. Let me just pull it up. All right, so you guys don't have a lot in the capital budget. A lot of it is related to St. Elizabeth. So I just want to ask about some of the projects that the funding was not expended for. So first you have a thermal docking station system.
These are saying.
It's about 1.7 million. Where's your St. Elizabeth's person?
Okay.
So,
It says you didn't spend anything in FY23. The explanation says it's in process. I want to know what that means.
we actually have just gone through a review of all of our capital projects with the funding committee. And in process means for a number of reasons, mostly resources, shortage of resources, through partner agencies and getting outside resources during the pandemic, things were delayed, but that particular one is in process of having the upgrades to the thermal docking stations.
Okay, so I should start seeing expenditures in FY24 for that particular
Yes.
project. Okay, what about the intercom system? You had funding in FY23 and nothing was spent.
Introduce yourself.
That's good. Good morning, Chair. Mark Chastain, St. Elizabeth Hospital. This is regarding the capital
Right,
project at St. Elizabeth.
right.
Yes, so I'm asking about the intercom system. You were planning to do that project in FY23. You didn't spend any money on it. In here, it says in process. I want to know what that
Yes.
means.
It's in process. So I have a detailed analysis of all the capital projects, including that one for you. And we'll provide it for you right after this session. And that project is in process. And we have begun phase one of it. And in fiscal year 2024, we will complete the entire project.
Okay. Um, let's see what else we got. Flooring replacement in process.
100%
Almost done.
complete.
It's now complete.
Yes.
Yes.
Okay, you guys should
All
update.
12 units, yes.
Mhm.
All right. HVAC modernization?
Done. I
That's
have a
complete.
detailed analysis, each one of those projects for you.
Okay.
We have prepared for you.
So
But
here's
go
the
ahead.
thing, I'm reading from the documents that you all submitted. So if
Yes.
these projects were completed, then the documents that we got, what, a week ago are out of date.
Oh, we have refined them.
Okay,
And we have a detailed analysis for you. That'll give you detailed, real-time information about each one of them.
okay. Dr. Bazar, this one is more mainly for you, I guess. We have some leftover funding from the Stabilization Center Design and Construction, the first one, the K Street.
Mhm.
Is it the intention that this will be moved on to the next project line, or are there some punch list items that need to be closed out?
That will be used to upgrade the remainder of the facility at 35 K Street. That facility, as you know, is pretty old
Mhm.
and needs a lot of work. And so as a part of this whole process, we also planned on doing some facelifting of the remainder of the facility so that the environment is upgraded.
Okay, so you're talking about the upper floors?
The upper floors and the other side of the first floor. As you go in
From
on
the
the
front.
K Street, correct.
Got it.
Mhm.
Okay. Okay. Sorry, I'm flipping through because I only have 2 minutes, so I'm trying to ask about something that. All right, so on Monday, we heard a witness from DC Action. They said that the Department of Behavioral Health had been collaborating with DC Action and the Youth Economic Injustice and Housing Coalition to develop a traveling mental health pilot aimed at providing services where youth congregate to increase accessibility. But that has not happened. So what's the status of this partnership or collaboration or the conversations that you all have been having about a mobile
Mhm.
mental health unit for young people experiencing homelessness?
Good afternoon. This is Megan Sullivan. Nice to see you all. I'm the interim deputy director for Child and Youth Services. We were listening on Monday morning, and I believe she also mentioned a program that is within DHS. And so I believe that mobile crisis unit is with them with the homeless. And so we can follow up for sure.
Okay, but you have no recollection of this type, because I remember last budget time, this was an ask. We weren't able to fund it. And so it was even sort of surprising to me. She said, oh no, we've been in conversations with the agency and we were going to do it. And so that's why I was like, oh, well, perhaps DBH picked it up even without the funding. But perhaps it's a different agency.
Yeah.
Perhaps.
Okay. On the idea though, even if it were the Department of Human Services, would this not be something that the Department of Behavioral Health would be collaborating with them on?
Mhm.
Absolutely.
Absolutely.
Okay. All right. We'll follow up with them on that. And I will yield back my 32 seconds. Councilmember Parker?
I want to pick up on the transition services at DC Jail. Dr. Bazaran, I recall you saying that you are providing transition services. Can you detail what those services include and who might be the point of contact?
Yes. First of all, the point of contact is Dr. Chad Tilbrook, who is our Director of Forensic Services. And he is here.
And he just appeared.
He just appeared. And we do have a whole range of services and supports. We work very, very closely, not just with the jail, but also with the Federal Bureau of Prisons in terms of reentry. And so he can speak.
And
to both of
before
those.
Mr. Tilbrook speaks, that grant that was flagged, I think with Community Connections was the name, that ended in 2022. Are you familiar with the grant that? what's the status there? Have you all sought to renew it, replace it? Or are you suggesting that the current services are in lieu of that grant?
Yeah, I think that the grant that Community Connections was referring to was not here again with our agency, but we work so closely together. Sometimes it may be difficult
Got it.
to know which agency it's with.
Okay.
So,
Councilmember Parker, thank you for the question. I'm Dr. Chad Tilbrook. I'm the Director of the Forensic Service Division at DBH. To your point, to the latter point, the question, that grant was not part of DBH. We were not involved with that, but we do support transitional services, reentry services in 4 separate locations. First, and primarily at the DC jail. We work closely with the Ready Center and the Department of Corrections by doing both pre-release and post-release support and transitional services. 30 days prior to individuals released from the Department of Corrections, I have co-located staff that actually reach out and touch everybody on the units that are being released.
And that's for every inmate at DC jail would receive those services?
Correct. We do not pre-select them. We don't pre-identify them in any way. Anybody that we've identified based on weekly reports of their population that are being released within 30 days, we touch them. We approach them, offer them services, both mental health and SUD services. We also, and we're touching approximately 100 people per month and linking about 70 people per month to services, either relinking them to services that they had prior to incarceration or establishing new connections. We also have post-release services at the Ready Center. So individuals who we may miss or may change their mind after they have been released can walk into the Ready Center. We have DBH staff that are co-located there that can do post-release work. The third location is at DC Superior Court. I have co-located staff that are there that catch individuals that are being released that were previously detained but are being released directly from the courthouse. We work closely with a DOC liaison at the courthouse to try to link individuals from the.
Is that everyone, or do they have to seek out your services?
We get a list of everyone that is being released every day from the Department of Corrections from the courthouse. Again, it's a different population, but
And
we wanna make
therefore
sure-
you're then making outreach to them?
Correct.
Got it.
Yes. Yeah, we approach them prior to their release to the community. So they're still detained in the courthouse, and we're touching them at that point, and also giving them information about the Ready Center. So in the event that they also change their mind, they know where to go to get help. The fourth location is we have co-located staff with CSOSA. So these are, we are capturing those individuals that are coming back home from the Bureau of Prisons. We work closely with CSOSA as well as the Bureau of Prisons, and we're touching and working with these individuals about 4 months prior to their coming home. So we work very closely with them to do care coordination, to make sure that services are in place, including appointments, right before they come home. We also support, but not to such an extent as the other locations, U.S. Probation and the U.S. District Court as well.
Okay, that is super helpful. And while what I'm hearing is that grant was not connected with DBH, but there are a range of services being provided. And it seems like to the majority of people that are either in the jail and or shuffling through our courts, as well as services at various locations. So
That's correct. I have 4 designated individuals that are working in this population. And by the end of February, I plan on bringing on 2 more, including a forensic peer navigator who will help individuals with serious and persistent mental illness being transitioned into the community to make sure that they are.
now
connected
what
to
I
care.
did not hear, are there any services provided at DRS facilities? I'm
Not-
thinking about juvenile focus services. And
not by
so
us.
I'm hearing DC jail, Superior Court, those are
Mhm.
very important. I'm not hearing any youth focused services.
That's correct. DYRS handles their own care coordination.
Okay, I think that might be a gap given what we're seeing in the city. And we know for a range of reasons, our young people are not receiving the support. And so that is a clear opportunity, I think, as you're moving forward. I wanted to switch gears to the Opioid Abatement Advisory Commission. Dr. Bazaran, how would you characterize the commission? How is it going?
Um, it's been an interesting experience. I think that we are uh, hoping to work toward some group cohesion. It's not there yet. And also we are working to get some decision-making in place. We do have a chair and a co-chair who's named, who are
And the chair,
actually,
Mr. Jackson, right?
the chair is
Yes.
Chad Jackson, right? And we are really working to support him so that we can move to some decision-making process so that we can get money out the door. But it's been difficult.
And why has it been difficult? Is it because there are such divergent views and perspectives? Can you just tell me more why it's been so difficult?
I think there are divergent views and perspectives about how things should operate, how money should be distributed, who should get it, and so forth. And so we have spent the past meetings really dealing with process. And now we're at the point where we really need to deal with, the action agenda.
Okay, and it's my understanding stated goals have not yet been established for the commission.
Well,
Or
there
those-
are goals, of course, within the legislation that we have to follow. But in terms of the specific areas
Yes.
that will be used for distribution, that decision has not been made.
Two more questions here. There was a discrepancy in how some read the initial legislation. I would love your perspective about the commission's authority to allocate money.
The commission,
Some think the commission provides recommendations and the council dishes out money. And then others think the commission has the authority to actually dish out the money. What is your perspective as the agency responsible for overseeing the
the
commission?
commission has the ability to recommend how the fund should be spent.
So I'm hearing you say the commission cannot dictate the spending, merely
is-
recommend.
That is my opinion, yes.
That is helpful. And then about the sobering center, and this is hearsay. I've heard that there may be a switch, a bait and switch of sorts with funding for the sobering center. Maybe some trying to tap the opioid abatement commission's funding to pay for it. I'm seeing
No,
that's not accurate.
no, there has been no discussion about that. As a matter of fact, one of the things I should share with you is that the contractor or the
Yes.
provider at the center also now is Medicaid eligible. And so we'll be able to bill Medicaid directly for services in addition to the SOAR and the local funds that are available to them.
Beautiful.
So there's been no discussion about using opioid abatement funds to support that effort.
Awesome. And even if there were, it sounds like you're saying the commission would merely be able to recommend
That's
the use
correct.
of those funds without allocating. Got it. I want to switch gears to your pre-hearing responses, the SUD facility for youth. It sounds like from your responses, you're planning for the first week of February to issue a RFP. Can you speak more to what will be included in that RFP and what ultimately the goal is for this youth-focused 3.5 SUD facility?
First of all, we know that there is we don't have a robust system of care for young people
Yes.
with SUD services. And so one of the things that we have done, and Dr. Sullivan has been responsible for this, is develop a RFP so that we can get that service and support for our young people. So when they need residential support, they can get it. Right now, we do have outpatient services available. We are also working very closely with Dr. Colin Murphy, who is at Howard University, and Children's Hospital to look at his outpatient clinic and how that might be used to either further expand the services, but I'll let her talk about the residential.
So it was actually posted on January 25th, and so the applications will be due on February 15th. So we're very excited about that. Speaking, as Dr. Bazaran mentioned, it's a 3.5, level 3.5 residential facility for youth, and really trying to bolster the system of care for individuals who are struggling with substance use. And so in addition, it's been a joint effort in that we've really gathered information. Obviously, providing services to youth is a bit different. You have to have the educational component, so that's also there as well since it's inpatient. And so, go ahead.
So February 15th is the deadline for applications. And when ideally would you expect the facility to be online?
Again, that's going through, we have to go through the OCP procurement process. So obviously there's a review board, and then it'll be awarded.
And when you're dealing with OCP, this is a issue that keeps coming up. Do you feel as though you have the ability to leverage your expertise in choosing a provider versus vague guidelines, whether it's the lowest bid or the concern has been raised by different agencies that we have the expertise, we have the knowledge of who might be best, that and OCP sometimes don't. So, I mean, what has been your experience?
This experience especially has been extremely collaborative. So within programs myself, as well as we've been working with the adult SUD providers as well to learn from them as well as also to give their information. And we've been working closely with OCP. So I would say it's extremely collaborative. Obviously, there's processes on both sides, and we have
I
our
got you.
expertise.
So coming back to when ideally you expect the facility to be online. So assuming all things go as best as they can with OCP.
Again, I think it depends on the applicants, how many there are, the review board, and then them making the determination.
And where is the facility slated to be located?
Ideally, the way it's written in the RFP is it's DC or within, I think we put 50-mile radius.
So I know
it
there were
will-
also sections about racial equity.
Mhm.
We know that many of the challenges that this facility will seek to address center on Black youth,
Right.
impoverished youth in the district, which are in large numbers concentrated in parts of the city. And Dr. Bazaran, this may be for you. How will we ensure with this facility that it's not located in a part of the city where the need may not be as great as some
Well,
others?
I think that I'm glad you raised the term racial equity, and we really do use that as a part of the evaluation criteria. And so the program staff with expertise in SUD will also need to rate the provider in terms of that equity lens. We're looking at it through an equity lens, and so that won't be missed.
And that's important for the provider. I'm talking about the location of the facility.
Well, no, I mean, but that's a part of their, of what they are offering is the location will be here.
Mhm.
The services will be these services, and this is how they will be implemented.
Okay.
So all of that is a part of our consideration. And so if it's someplace where we feel is
I
not the
got
right
you.
place, then
And
we'll be able to weigh
I'll
in
be
on that.
explicit in my last 6 seconds. I think we need more services in wards 5, 7, and 8, given where the numbers are. And so I'm hoping when that facility comes online, it will be direct access for youth in those parts of the city. Thank you.
Yes.
Thank you, Councilmember Parker. Councilmember Nadeau?
Thank you, Madam Chair. Hi, Director. So as we heard in the public testimony, there are gaps when individuals are discharged from inpatient treatment services. And patients often leave treatment without additional support, and there doesn't seem to be a handoff process with community-based organizations who can continue to provide assistance. What's the current discharge process, and how does DBH collaborate with other services in the discharge process?
Well, first of all, we do have intensive care coordination services available for anyone stepping down, excuse me, from a hospital. And we have a whole team that is responsible for having those relationships, doing in-reach with the patients, and then working with them as they step down, and then providing, like, particularly for complex cases, providing care coordination over a period of time to make sure that they, in fact, get the services and supports they need. That is a part of our adult service delivery system. And as you may recall, we actually created that intensive care coordination unit a couple of years ago and built in that process.
You mentioned hospitals specifically. Does that cover the full range of inpatient treatment services?
Yes. And,
Okay,
we have a particular focus, obviously, on PIW.
sure. And I know you were listening intently to the public testimony as well.
Mhm.
What did you take from that testimony? Did you think that, was it just some confusion, or what do you think they were specifically talking about?
Well, we are here again are working closely with PIW to ensure that there aren't any gaps
Mhm.
in terms of communication, even though we do, in fact, make frequent visits to PIW so that we know what's happening. We do checks to make sure that people are getting the services and supports that they need while they're there. And then certainly we do the follow along and the care coordination as they step down. And so I think that there have been some issues raised around PIW, and both the Department of Behavioral Health in partnership with DC Health are really working to get those corrected. They have a
Great.
new CEO, as you know, who came on board a few months ago. And I have monthly meetings scheduled with Dr. Oma, who is the new CEO, and I'm hoping to be able to rectify some of the issues that we have found. So it's not perfect. We know that we have to work on that.
Very good. Thank you for reflecting on that. I appreciate your insights. What type of information on patients is shared between DBH facilities, certified providers, and other service providers in the intake, treatment, and discharge process?
In the, I didn't
Intake,
hear the
treatment.
last part of your, I'm sorry.
Oh, in the intake, treatment, and discharge process.
Mhm. Well, certainly, as you know, through HIPAA, we can share information with those individuals who are responsible for treatment. And so we do share that information. In addition to that, we are really working to even further improve that process and we have required and mandated that all DBH providers have bidirectional connection to CRISP, our HIE. And that means that they not only look into CRISP to see what's happening with the patient, but also they have the ability to input information, and they have a requirement to input information into CRISP. We think that that's really going to make a big difference in terms of information sharing. So you won't have to get on the phone and just call whoever might have seen the person, but rather you can look in the HIE and see what's happening. And so I think that um, the fact that DBH actually worked with our providers. They were actually provided additional funding to have an EHR that was certifiable, will make a big difference. And we really thank the Department of Healthcare Finance for their support around that initiative.
That's great. Now, there are other parties not covered under HIPAA that I know it's more challenging to coordinate with. I'm thinking, for example, of folks who, say, manage a residential community and are trying to support residents who are receiving services from DBH and community-based organizations that contract with DBH. How do you navigate that, and sort of what are the best practices in ensuring that those clients are supported also by their residential community management and leadership?
Well, what I can think of off the top of my head are business associate agreements, which really provide individuals an opportunity to receive information. But I must be clear that confidentiality requirements are things that we have to adhere to. And so
Absolutely.
we do that. We work in partnership with people within the community. And then our team will follow up and provide those services. But we cannot violate confidentiality laws, and we don't.
Absolutely understood. And I think that's just, one of the other things that we have to, it's a challenge to
Mhm.
sometimes
It's a challenge.
it's a challenge for those who are trying to truly be supportive. I'd love to hear more about what your thoughts are with that business associate agreements and how those work so I can make
Mhm.
others aware of it as appropriate.
Sure. Oh, okay. And I can really follow up and give you
Oh,
information regarding that particular thing, but it's for others who may be providing some service or what have you on behalf of the individual.
got it. So maybe for just non-clinical positions.
It depends. Let
Okay.
me follow up with you on that.
Okay,
Okay.
I'm very interested. I'd love to know. I'm always trying to figure out how we can, work through those challenges to provide additional
Mhm.
support since we know there is a community of
And
folks
I
who
think
want
it's
to
a
be
good
able to do it.
question, and it's one that we'll give some thought to.
Fantastic. Thank you. I appreciate that. Um, During public testimony, we heard from a few students about the lack of awareness of DBH resources in schools. What
Mhm.
resources and guidance does DBH provide schools and school-based behavioral health staff on outreach and dissemination of information on the program for parents, teachers, and students? I'd love to help figure out how we can increase awareness of the programs.
Thanks so much for the question. And yes, you're right. We were listening. We were listening as well, and so heard the students. One of the particular things that we've done this year is we worked with Aussie, DBH worked with Aussie, and we actually created posters for the beginning of this school year, both in English and Spanish. And they're rather large posters so that we can give exactly the name of the clinician, where to get help. And so those are posted in DC Public and public charter schools, as well as we've done some more innovative things this year and use things like QR codes because we know especially high school students are more apt to use their phones, right? And so we've done QR codes to try to link to referral forms, as well as to give information about who the clinician is, but also who's the school behavioral health coordinator in the school. We also heard about those on Monday as well. And so really trying to give information about where to get information and how to get information. So those are a few things that we've done this year, as well as we continue to go to back to school nights, information sessions and classrooms. So there's lots of different strategies that we've used.
That's great. Do you have a way of tracking how people are accessing the services, how they're learning about the services at all?
It's a great question. I mean, I think it varies, especially across grade bands. But that's something that we can, we can't think of right now exactly how we tap into it, but I think that
Yeah.
is an important thing to think about.
And it might be a good intake question to add, just so we know, since you're investing in these different.
I think we know for the youth who are entering into treatment services, but for those, as you know, school behavioral health is based on the public health model. So for
Right.
the students who are receiving treatment services, we definitely know the referral source.
Understood. Given how many different immigrant populations we welcome into our schools, have you seen a need for materials in languages other than English and Spanish?
So I specifically have not, but we have the ability to translate into other languages and in DCPS and as well as some of our other LEAs translate all their materials into other languages.
Do we have them translated in any other languages at this time?
The posters specifically or
Well, other materials. It's fine if the posters are just two for now. I'm curious
yeah, the
about.
posters are, to my knowledge, just English and Spanish, but some of the materials have been translated.
Thank you for that. Different topic. In pre-hearing questions, DBH noted that the agency doesn't currently have a formal wait list for your housing program. I'm looking at the intensive housing care management program, but that the current wait time for the program is 4 to 6 weeks. Can you provide the average number of people waiting for the program at a given time?
Waiting for which program? I'm sorry.
The housing program, the intensive housing care management program.
Oh, intensive housing care
Am I
management?
using the wrong phrase? I'm
Yes.
sorry.
I'm sorry, I just couldn't, I'm having difficulty hearing you.
Oh, I'll speak up
Yeah.
as well. No
Okay,
problem.
thank you.
Thank you for letting me know.
Council member, I presume you're talking about the mental health
Yes,
facilities and the different levels of care we have
Mm-hmm.
there.
thank you. Yes.
There is not a wait list.
No wait list.
I think across the various levels.
Uh-oh, I think your mic might be off. There
Sorry
you go.
about that.
That's
Do I have to
okay. It's
start all-
actually your hand.
Do I have to start all over?
Yes.
Not
Okay.
all over, no, just the
I'm
middle.
sorry. I'm sorry. I believe you're talking about the mental health community residential facilities, and there are different levels of care there. I believe we have about 900 and something folks in those facilities, from the low intensity to higher levels of intensity. There is not a waiting list. You know, people can be placed, assuming they meet eligibility, within about 8 to 10 weeks. And the vacancies, in terms of somebody qualifying and we have a slot available, there's not a lot of movement in those facilities because people are in great need when they're
Yeah.
in there. And they're in
Yeah.
there for a long time, and we're wrapping services around them, but they don't move. It's not like a voucher program. So people tend to move out, or slots become available when there's a major life transition. So the delay, if you will, not a waiting list, occurs when, because of the process, the paperwork, somebody has to
Got
be
it.
evaluated.
It's
It's
administrative.
a process, and that
Mhm.
can be 6 to 8 to 10 weeks, but there's no waiting list. And
And
assuming
is
there's
that something that we seek to reduce, that length of time?
with each individual case, we have specific folks. We have a residential support services team that's really working with the CSAs. When they identify people, we have meetings with CSAs asking them to review their roles, to review and consider who might be available and in need of housing, and to facilitate the process. So it's really an individual process that our team is very engaged in, trying to support and move
Is
forward
it the
as
type of
quickly as
process
possible.
where there's a lot of back and forth of collection of materials from the
Right.
individual and it may be
Yes.
challenging? Okay,
That's
I understand.
That's a lot, not like making a referral to an inpatient facility or a hospital. It's much more
Understood. Yeah,
involved.
you've got to gather a lot of documentation. I
Right,
get that.
correct.
Okay. Okay, thank you for that. One final topic, as you noted in your pre-hearing responses, during FY23, CHAMPS hours were reduced to Monday through Friday from 8 a.m. to 8 p.m. You also noted that the DBH CRT team is answering calls to the CHAMPS line outside of these hours. However, we heard in public testimony that there have been cases of MPD responding to calls when CRT and CHAMPS are unavailable. Does DBH track how often teams are unavailable and when MPD has to be involved?
Yes, and first, and I'd like to say that the CHAMP services have not been reduced. And Dr. Bebout can speak to that in terms of how those services are being conducted a little differently than they were before, particularly nights and weekends.
Okay, please do.
Thank you. One point of clarification, CHAMPS is the program which is now jointly operated by Anchor Mental Health and by the CRT. That is the Child and Adolescent Mobile Psychiatric Service. CRT is administering that program after 8 p.m. until 8 a.m. weekdays and on the weekends. The contract was restructured for two reasons. One was the Anchor team was having great difficulty staffing the overnight and weekend hours. As a result of that, calls for assistance, although the volume frankly was low, the way they were understaffed meant it was more likely that calls would be diverted to MPD. Under the new structure, we believe firmly that, and we are tracking data, I can follow up with you about that. We are tracking data about, but we believe that calls to the CHAMPS number after hours and weekends are now more likely to be responded to by a clinician or clinical mobile team than they are, than police, than under the previous configuration.
I'd love to see the data on that when you have a moment to share it. And I am over time, but I want to make one point, which is if if the agency's saying that we have continuous coverage, that's one thing. I think one of the concerns about the shift is who the coverage is and the specific training that the CHAMPS program has for youth, not being the same that CRT has.
In our written responses, we did describe the training that CRT team members underwent in the run-up to the restructuring of the contract and the assumption of the after-hours and weekends coverage. We
Yeah,
also actually have team members at CRT who were formerly employed by Anchored or other children and adolescent mobile crisis units in other locations. We have also recently taken steps to add a children and adolescent youth crisis coordinator to my team,
great.
who will be consulting with CRT and Anchor in the administration of the CHAMPS program, along with our new Chief Clinical Officer, Dr. Jonathan Shepard, who is dual boarded in child and adolescent psychiatry.
Thank you very much for your response. I appreciate it. Thank you, Madam Chair. I will see you next time.
Thank you, Councilmember Nadeau. I want to pick up a little bit on where, well, since you're already here, Dr. Bebout, I know to pick up a little bit more on some questions about CRT. Are CRT staff salaried employees or hourly employees?
They are salaried employees, and the majority are members of a union, but they are salaried employees.
Okay. One of the things that I guess I'm concerned about, and I'm curious if you are concerned about, so I understand from a earlier question to a colleague, you said you currently have 18 positions in active recruitment.
Correct.
Okay. Recognizing that the CRT team is not easy work by any means. How is staff turnover and retention?
I can provide additional details, but and do an analysis of that for you. But again, these are really difficult positions, as you just recognized. I think our retention levels are reasonable for programs like this. We are looking at adding additional staffing supports in terms of debriefing protocols, working with a national expert on trauma informed care.
Like, what's the average length of stay for a CRT member?
I don't know. We'd be glad to get that for you. But
Okay.
we have many, many employees that have been with the agency
years.
since prior to the creation of CRT, who came from the legacy programs, including homeless outreach and mobile crisis and the pre-arrest diversion programs.
Okay. How many teams do you have deployed for the evening shift?
So when you say teams, we deploy in pairs. I can give you a mapping of how we are staffed over the course of the week, as well as where the vacancies are. But
Is a
we always-
pair enough?
I'm saying in terms of a specific deployment.
No. You said we deploy in pairs. And my
Yes.
question is, do you feel like 2 people is enough?
Yes.
Yes.
Okay. Because I think that, hearing from some of the testimony about some of the things that they're facing, if you all felt like you needed to move up to teams of 3, perhaps, right, to add some additional support, do you have the capacity to be able to do that?
So I don't foresee doing that on a routine basis in terms of really high acuity kinds of situations. There's always a supervisor on duty. A supervisor may also go out into the field and join the team on site. Those kinds of situations do come up, and we are working to solidify protocols, not just when they can, but when they should seek additional support and supervisory consultation.
Okay. One of the things that one of your team members mentioned was not having access to the ACT notes. What obstacles exist to providing this access?
Yeah, thank you for that question. There has always been partial access. The teams do have the ability to, and moving forward as things continue to evolve, we will assure that they have regularly refreshed lists of people who are connected to ACT teams and who those teams are. Um, I don't see that as a barrier.
Okay. All right. So we'll check in on that in March or April or the next time that we see you guys for budget, just to kind of see, because, I'm not trying to think of this as surveillance of the ACT
no, no.
teams or anything that,
No.
but there might be some valuable information that a CRT team member might find from those notes before they go into a particular situation.
Absolutely. And if I may just elaborate a couple of things. One is there's tremendous amount of work has already been discussed about strengthening the quality and fidelity of ACT implementation. The stronger, the higher the fidelity of ACT, the less likely somebody who's connected with ACT services is going to be reliant on CRT to address a crisis. High fidelity ACT means that they're 24/7, and the ACT teams themselves, who know the individual best and are best positioned to provide a high quality response, are going to be responding. So we work very hard to either co-respond with ACT team members or to activate the ACT team members because it's a more integrated, higher, produces higher, better outcomes.
Okay. Let's talk about SUD residential treatment. I know that colleague asked specifically some questions about the youth, but I want to ask some questions about the adults. Providers have certainly expressed some substantial amount of concern about this shift in practice to needing a medical necessity requirement every 15 days in order for an individual to stay and receive care. They say it's disruptive, it's costly. There are lots of different things, right? How much progress can you make in 15 days in terms of those determinations, et cetera? How does this policy align with the approach of other jurisdictions?
I'm happy to address that. That whole area reports up to me. Thank you, Dr. Bazran. I think it's important to give a little context to the council members and others who may not be real familiar with what we're trying to do here and how it came about. What happened was, so if you'll forgive me, just giving a little history and a little context. In 2019, Medicaid was not able to cover long-term residential treatment. As part of the 1115 waiver, Medicaid was successful, and as prior to that point, people could go into a residential treatment paid for by Medicaid for 14 days. So as part of the expansion, it opened up the system so people could not only be treated for the first 14 days within an IMD, but in the community beyond that point as of 2019. Part of the regulations and requirements of Medicare, CMS, and Medicaid is that as a result of that expansion, there needs to be a quality review process to ensure not only people are at the right level, getting the right care, but the care is being integrated and managed appropriately within that level. There's about 65 to 70% of people in long-term residential SUD care have a co-occurring mental health condition. So do you have a psychiatrist in the house or a mental health professional? If not, how are you coordinating with community psychiatric resources that have a history on that person to ensure the care is integrated and you're making the best use of the time in treatment? So as a result of the Medicaid requirement that there needs to be an external quality review organization, EQRO, DHCF and DBH instituted a program where we could help providers develop the expertise and the tools and the skills necessary to work within a system which requires prior authorization for continued stay in SUD residential, especially given that we're moving towards the migration of all our services to managed care, to the managed care plans. And that's the system that they're currently using, including the criteria set, the clinical framework that we're currently using. So starting in January 10th, I believe, 2022, DBH and DHCF began working with providers saying, this change is coming. We have to impose a quality review process on continuing stays for residential care. And these are the reasons we need to do that. And this is the process we're going to use. This is the clinical framework we're going to use, which is called the ASAM Placement and Criteria Guidelines, ASAM standing for American Society of Addiction Medicine, one of the most widely used clinical frameworks for that purpose around the country. And basically, we worked individually with providers and as a group for 2 years, from January 10th, 2022 to November 1, 23, just a few months ago, to help them understand what we're doing, why we're doing it, the guidelines and requirements, and how their workflows may need to change to be successful.
Can
in
I
that
ask a
environment.
follow-up question?
And so throughout that process, we continued to pay 100% of the care that's being rendered, but helping them understand that their workflows and processes may need to change.
Can I ask a?
Madam
Oh,
Chair.
I'm sorry. You're right.
So, all right, CMS made a change, says you need to do a quality review. Now instituted this external reviewer. Is this CoImagine?
Yeah,
Correct.
the vendor is co-managing.
Okay. In January of 22, when you all started to implement this,
Mhm.
up until now, how many denials have there been?
0. And in terms of non-payment because the care did not meet medical necessity criteria according to the ASAM guidelines, 0.
No, not non-payment,
Oh.
but the inability for someone to go beyond 14 days.
And by the way, just to clarify, it's the cycle of review is 14 days. It doesn't mean like you have to complete treatment and achieve all the goals within 14 days. It's like every 14 days, we're going to look at how the patient's progressing, what's going on, if you need to coordinate with the psychiatrist in the community, how's that going? Can DBH help and so forth? So, but I think at the beginning of the process, 2 years ago almost, most of the providers, because they traditionally have had a very traditional different treatment model, more of a community-based therapeutic model that wasn't driven and determined by clinical medical necessity guidelines. It required a lot of work
So what,
with them.
you're saying a lot, and I appreciate the context. I also have providers who are saying, I have patients who need care beyond 14 days and they are being denied their ability to stay in our residential treatment facility beyond 14 days. And so my question, you said how many denials, or I said how many denials, you said we've denied no one for non-payment. Then my question was, how many people have been unable to stay beyond 14 days because CoImagine has determined it is not medically necessary?
So what I was trying to clarify, please forgive me, is before November 1 of 23, stays were reviewed. We used it as a teaching training opportunity, but the whole length of stay was paid for. Starting November 1, 23, 87% for one residential provider of their care was covered for like an average length of stay of 30 days. And another, it was 98%. So
yeah.
no care has been denied. The length of stay is being managed differently, but no care, no.
Right,
care has
but
been
I
denied.
think the length of stay is connected to the care you're,
Now, with
you're
if
receiving.
I might, Madam Chair, the whole purpose of having this external quality review and using the ASAM criteria is to ensure that the individual receives the right level of care at the right time, and then can move to the next level of care to make sure that they get quality services. So what that means is that the provider then has to, using the quality metric, using the ASAM criteria, which they have been trained on, submit appropriate documentation so that for an approval of an extended time period. And so if somebody needs residential care, and if they meet that criteria, they will get it. for as long as they get it. So this does not obviate the fact that people can stay longer than 14 days. It
Okay,
is not, that is not the case.
so if a person is unhoused
Mhm.
and you've determined medically they have stabilized in 14 days, even though they don't have any place wherever they are likely to go, they are likely to reuse again.
Mhm.
How do we evaluate that? Because in some situations, like let's take Samaritans and for instance, where you have an individual who, whatever their previous housing situation is such that that is not a conducive environment for their treatment.
Mhm.
So they're receiving residential treatment, they're there. How they are presenting it is DBH and healthcare finance are basically saying that is not a consideration. It is whether or not you still need
The treatment,
the treatment.
that's correct.
So then that begs the question of what other people brought up is around us not appropriately discharging people to the, well, us discharging people to perhaps not appropriate situations.
Well, here again, the residential treatment program is a treatment program, and it's not designed as a housing program. And so you are right about that. The
Right,
person.
but if you're receiving
the-
treatment while you're also being housed, right, is that it, well, let me ask
It
this.
depends on the level of care.
Is sober living and residential treatment considered different types of billing models?
Well, first of all, the other thing I can say is that we also have, and we have other kinds of housing available, environmental stability housing where people can be discharged there. Pardon me? We have recovery homes, we have Oxford houses. There's like an array of housing opportunities for individuals so that they would not be discharged inappropriately. And so the treatment program is designed to provide that residential treatment and that level of care. And that is a part of the requirement.
Okay, so I have people who are saying, we have witnesses who said we're discharging folks to shelters, and you're saying that's not true?
I don't know that we're doing that.
We have staff, residential services staff and other staff that will work with a provider to say if this individual needs to be stepped down to a different level of care because they can no longer meet the criteria, medical necessity, clinical criteria for the highest level, highest intensity level of care, to work with a provider in the facility to find appropriate, suitable housing for that person. We're not discharging, DBH is not discharging that individual to a shelter. We'll work with them as best we can to find out the resources available in the community and try to fast track and facilitate that process. But, yeah. And the provider has a responsibility too, to work with the resources available in the community to find appropriate placement. So we're not saying you will discharge the person to shelter. to
Right,
this
I
location.
understand it's not you, the agency, who is saying that, but I also think that in terms of the ability of supports available, in some ways, I don't feel like we're setting up providers for success. For instance, if I'm a provider, I have a person who no longer needs my level of care. Is it my responsibility as a provider to now call every housing opportunity to see if they have a bed available? Or is there a person at DBH I can call to see if there's a bed available?
Mhm.
We can help with that. Yes, I'm not saying we have the staff available to, be actively engaged in every one of those cases, everybody being discharged from SUD residential, but we have staff available to help with that process, especially cases that are more severe and extreme where the person hasn't been able to find steady, consistent housing in the community.
Is there spaces available in some of our housing programs? Oxford, you
Mhm.
mentioned a couple other places, Oxford House,
Yes.
et cetera. Is it possible you can provide the committee a breakout of how many beds are available
Yes, we
across
can.
those various things?
Mhm.
I'm over my time, but I just want to sort of just underscore on this point. At least what I hear from providers, not just in hearings, but in the meetings, is that they feel as though the agency is like, well, we gave you the money, so good luck to you. They don't
Mhm.
feel the level of
Mhm.
support in terms of navigating what is in some ways a very siloed system, right? We got sober housing people over here, we got residential folks over here, we got the clinicians over here, and all of these different things. And I understand that you all, you're conveners, obviously, you have convened conversations and bring those pieces together. But this is similar to what, PDS and other folks were talking about in terms of access helpline, which is in their view, right? That there is no longer a person I can call who can help walk me through a process. They're just going to hand me a phone number and say, good luck. And so to the extent that you all can sort of change that perception, because that is what people are sort of viewing across the board on how things are going. Councilmember Parker.
I want to move to school-based behavioral health, but before I go there, I want to get an update on the agency's thinking around overdose prevention sites or safe injection sites. I know you took a field trip to New York with members of the committee, and can you give us an update what you're thinking?
We took a field trip to the site in New York City, as you know. And what we saw was a community-based organization where safe injection was a very small part of the overall program. What we saw was a place that invited the community in for services, as well as individuals who might have substance use disorders into the place. There was everything from primary health care available there to giving massages and using other kinds of supports to help rebalance people, to case management services, to connection to housing, to one of the things that I found very interesting was there were a lot of people who came because that was a safe place for them to rest. And so they were on like Barco lounges, literally sleeping because it was more dangerous to sleep outside. And so I think that what my takeaway was is this is really a multi-service kind of agency that really provided, a system of services and supports for individuals. And the piece that gets the most headline was really a small part of it.
That sounds like an endorsement.
Well, I'm just saying that's what I saw.
And so what's the agency's thinking? Because last year during the oversight hearing, I recall you saying you're considering it, debating it, researching it. And now that you've done that field trip,
Well,
how has that informed what you're thinking
Well, I
about
think
bringing
that-
those types of services to
here,
the
I think
district?
that under the direction of the deputy mayor, we are also looking at still collecting additional information. We also want to go to another site, and that plan is in the works. And then based upon that, then to share information with our leadership and then get direction in terms of our next steps.
Is there any chance that a proposal might be included in the fiscal year 25 budget for one of these sites in the district?
I can't tell you that. I can't respond to that. I don't know.
All right. School-based behavioral health. We still have a shortage. According to pre-hearing responses, I think the number is roughly 67% of schools are connected to a provider.
68%.
68% of
Mhm.
schools are connected to a provider. Something that was interesting, you said DBH is leading discussions both internally and with the coordinating council on school behavioral health regarding using unlicensed professionals and possibly paraprofessionals to implement tier 1 services. Can you elaborate?
Well, I think that, as you know, and Dr. Sullivan can talk about the 3 pilots. We wanted to really be innovative in terms of how we might address the workforce shortage. And one of the pilots really looks at whether or not we could use unlicensed staff to do tier 1 services and then have
And for
the
those watching, give me an
Oh,
example. What is
prevention,
a
prevention
tier 1
services.
service?
Prevention, education,
So I
early
know-
intervention services. So healthy decision-making.
Got it. Got
and
it.
so on, okay? Those services, most of which are curriculum-based, by the way. And when I was, quite frankly, when I was a classroom teacher in the year whatever, I actually provided those services as a teacher,
Yes.
through that. And so, having non-licensed staff do that, and then having the licensed clinicians do the treatment services.
And give me an example of a tier 2 treatment service.
A tier two service is what happens when a clinician sits in a room and observes a child and sees that child may need a little bit more support than what he or she is receiving, and then begins to think about what kind of early intervention services are needed so that that child doesn't
And I know
develop
like
a.
suicide support, I believe that would classify as tier 2.
That's- Go ahead.
So often tier two or small groups, it could be
Right.
students who are at risk
Right.
of developing a specific diagnosis. So it might be
Mhm.
kids who are having trouble with conflict resolution. So a clinician may pull 5 or 6 students together in a small group and providing specific, very targeted information
Services.
about a
Mhm.
specific topic such as
Right.
social skills or conflict resolution.
Got it. And so that seems interesting, and I'm glad
Yeah.
to hear that you all are reflecting on how can we better use the resources that we have. That still doesn't address the pipeline issue. So if you have a
Right.
technician at the school, it's about how do we better use them, which is smart. How are you thinking about the pipeline and getting more
Right.
clinicians
And,
connected with
and
schools?
I'll have Dr. Sullivan talk about some of the innovations that we have put in place and some of the strategies to really build the pipeline, because that's a part of it. One is how do we better utilize the staff that are available? And then two is how do we build the pipeline?
Right, and so one of the ways that we're building the pipeline is at DBH, we have an internship program. So we have an internship coordinator who's working with, we create affiliation agreements with local universities to basically work with students who are in master's programs. And then they are placed in our schools and provide, exactly school behavioral health services, with the hope of obviously supporting them. They have a task supervisor as well as a supervisor at school to help provide support, in the hopes of we hook them. They love working in a
They stay.
school and they stay.
And how many participants do we have in that program?
So currently we have 4. We have students from University of Maryland, Catholic University. They work from 20 to 24 hours a week and providing not just treatment services, but also the prevention and early intervention. We're expanding. We're hoping in 24, 25, we'll have 8 interns.
Okay. And what other strategies are we employing for the pipeline?
So we also, you've probably heard about this, also received a federal grant. And so they have a project called Arrow. So we're collaborating and working with them as well to, one of the strategies that they've used is that they're creating a LinkedIn page. And so we used to talk about this in a pipeline. Basically, it's drawing all the people who are interested in working in a school, making sure that our CBOs are aware of these individuals,
Mhm.
who are especially at the end, right, in May, when everybody's coming out and is looking for jobs, and trying to link our CBOs with the graduating students. Some of the other things that we've done too is it's important to really support the clinicians who are doing the hard work. So as you know, we've done retention and recruitment bonuses. We've also done
How much
workforce.
are those bonuses?
Currently, it's about $9,000 through our grants that we give CBOs. In addition to that, we've provided $1,000 for each clinician to work on their workforce development. As you're aware, to continue to be licensed within the profession, you need CEUs. Also, those individuals who are not independently licensed, so what we refer to as LGs or LGPCs, they need hours, and they also need to sit for the licensing exam. So they can use those funds to help pay for those fees.
Got
And they
it.
also get free supervision, which is a really big thing to get those hours.
Got it. Got it. One of, in the mini spreadsheets that you all sent over, I looked at some Ward 5 schools and there seemed to be a trend of fewer services provided to young people this school year versus last year. I think Dunbar High School, for instance, that was an example. Can you speak to this trend of why there may be fewer services provided over a number of schools from last year to this year? Intervention services connected with the school-based behavioral health program.
So I think, just to back up a little bit, I think you're probably aware of this, but every year our clinicians in collaboration with behavioral health team and the coordinators, they do the school strengthening work plan.
Yes.
And so they
And we
incorporate.
have about 70%
Right. So
compliance.
they incorporate information from not only administrators, school staff, behavioral health providers, but also parents, youth, and they create a plan for that specific school. And it includes interventions on all three levels, so prevention, early intervention, and treatment. And so I can't specifically speak to your question at Dunbar, but again, what we do at the beginning of the school years is assess the need and then determine how we can implement and specifically who's going to do that, right? Because it's,
I guess what I'm getting at, like when I saw that, I thought about the truancy numbers, which are also high at Dunbar, and a number of our other comprehensive high schools, and was
Sure.
wondering, like, is it that there are certain young people that just aren't coming to school? Is it a matter of a lack of interest? Are clinicians just not checking in as regularly with young people? So it would be helpful if you could share now or follow up with us, like, how are you all calibrating the level of quality of the interactions? Like, yes, we know they have a clinician. Yes, we know there are interactions, but I'm seeing a downward trend at least a half a dozen schools that I just randomly checked in.
right. So we can definitely follow up on the specifics, but one thing while you were speaking that jumped out to me is we've created benchmarks. And so our benchmarks, while it allows for flexibility, as I mentioned earlier, it's important to make sure that the needs, because they vary from school to school, are identified by the individuals in the building. But as DBH and as monitoring the work, we do require specific things. So things like there's a specific caseload that we're looking for, number, right? There's specific, they have to implement prevention services.
Yep.
They have to engage with families and teachers and provide professional development. So while the numbers may be down in certain areas, we still are holding them and looking at the quality and quantity, to be honest, of all of these different areas.
Okay. And then Dr. Bazran, these questions are probably for you. Advocates are still pushing for compensation. Any thought or any thought to revisiting clinician pay? And I know you talked about the incentives, but in terms of baseline compensation.
Yes, as you know, we are and have, well, the assessment has been completed and it is going through final review. And a piece of that is looking at compensation and what is required. Right now,
You want to make any news about that?
in FY '24, the clinicians are receiving the $89,366 per clinician. That's what the CBOs are receiving. And that at this point looks adequate. It is much more than before. And we are, however, looking at what it needs to be moving forward. And we hope to have that information certainly prior to our budget review process so that we can really speak to that.
All right, a number I'm looking at that some advocates would point to, it's $98,465 per clinician. That's what they would wish to see. So just throwing that out for comparison.
Yes, we've heard that.
Yes. And I'm
Yes.
hearing you say you disagree because.
No, I'm not saying I disagree. What I'm saying to you is that You know, based on the information we have, we will then look at what our proposal is moving forward.
Okay,
And because that's a part of our budget process.
all right. The school-based coordinators, per your responses, 100% of schools have coordinators, even schools that don't have a provider. Is there any thought of compensating the coordinators? And I know at some schools, the coordinator may be an assistant principal, for instance. Any thought about paying people for this additional responsibility?
Can I take it or do you want me to? Go ahead.
As you mentioned, all schools do have an identified coordinator. They can vary kind of role. Many of them are social workers. As you mentioned, some are dean of students. Coordinators, I think the challenging piece with this, coordinators are currently staff employed. And so the way that we look at it right now is that funding for those positions is coming from the LEA or the school.
Okay. Okay. I think we should pay people, especially as we give them more responsibilities. And so that too is something hopefully you'll take into consideration as you're marking up your budget. I know we've been here a long time. The chairperson had to step out to another hearing. And I believe we're gonna go on a 10-minute break and then return for more questions, Director. Does that sound good? Great. All right, we will return at 12:08. Let's say 12:09, and then we'll resume. Thank you.
Great, and we're back. Okay, I was about to call you council member, Dr. Bazaran.
Yeah.
So I think we only have a few more sections and then you all can wrap up and head to a late lunch. I want to talk a little bit about the behavioral health carve-in. Obviously, we've had conversations. We've asked lots of questions of the Department of Healthcare Finance, from the time that the decision was made in terms of what is the transition process going to be taking place. And, for something that is about to transition in April, it feels to me that there's still a fair amount of confusion amongst providers around payment rates, requirements in terms of the transition to an associated managed care, all of these different pieces. So let me ask you this. Has your agency or healthcare finance established some policies and procedures on paper with dates and whatever so that folks can reference to as like, and this is the plan that's going to happen going forward?
Mhm, mhm. As a matter of fact, yes, we have. Tia Frame has joined us. She is, as you know, our Director of Policy and Accountability, and has been really providing leadership around this issue. But we have spent, I must say that we have a very close working relationship with the providers, both Director Bird and I. And we have not only done things verbally, but we also have written transmittals. We have a website that posts information. We have PowerPoint presentations that also outline all of the requirements, both during our forums and so forth, as well as our provider meetings, which happen monthly. And so I'll turn it over to her, and she can give more of the details related to that.
Okay, if in your response you can, we have a question of, is there a like centralized internal website where providers can go to find information?
Yes.
Okay. Good afternoon, council members. My name is Atia Jackson. I'm the Deputy Director for the newly named Data Quality and Compliance Administration within the Department of Behavioral Health. And as Dr. Bazran said, I have the opportunity to facilitate meetings between the Department of Healthcare Finance and the DBH Certified Network of Providers. To answer your question, yes. And it is clear that there are opportunities for improving our communication based on the number of questions we've received through the public forums that Director Bazran and Director Bird host, and from the follow-up with the public witnesses. As Dr. Bazran said, we've had many opportunities to meet with providers through public forums, which include advocates and community members. And we have, with our partners at the Department of Healthcare Finance, developed a website with information. So if you go to integratedcaredc.com, you will see a plethora of information on resources for revenue cycle management, training for providers, video recordings of forums that have been held with the managed care plans and the provider networks last year. But we know that this transition is important. It impacts residents, it impacts our provider network. And so we are, we will be looking at the communication we're doing and making sure that it's clear, consistent on many levels, not just on websites, but we got feedback from a public forum that we needed to provide some more in-person outreach.
Okay.
And so we'll be addressing that as we move forward and closer to the April 1st date.
Okay.
Right.
So what transitions on April 1st? I
Okay.
imagine for all services or just for some?
All of the behavioral health services that are currently within the 1115 waiver that our providers are providing right now will transition. All of our billable Medicaid services transition to the MCO. There are some services and supports that we will continue to provide, and that includes things like our crisis services, the stabilization service, which is a contract, urgent care services, access helpline services and supports, our MHCRF services
Okay.
and supports, and of course, our whole portfolio of grant and contract funded supports. But all of the Medicaid services will be carved into the MCOs.
I imagine that there's staff at DBH who deal specifically with the Medicaid services and the community-based organizations. In this transition, does it also include a transition of some DBH staff to healthcare finance?
The transition includes form following function. So Dr. Bazran has been clear, we're not doing any reduction in force as
Okay.
a result of this transition. She's also stated in previous forums that we're shifting into a whole person care model and a public health care model for behavioral health. So staff may transition to different roles within the department, like specifically in my team, because we do a lot of work with Medicaid. But that's a process. A light isn't going to go off on April 1st where somebody's going to come into their cubicle and, oh my gosh, I don't know what I'm going to do. As we've talked about in previous forums, there's an 18-month transition. That's not just for the provider network and for residents. That includes the people who are doing the work at DBH.
Okay.
And beyond.
I just want to confirm on the record,
Mhm.
there's not going to be a reduction in force due to this
No
transition.
reduction in force.
Okay, what will the role of the assessment and referral center be after April 1st?
That role will continue.
The arc will continue.
Okay. All right. Now we did hear from folks that you all have done communication in terms of providers, but they don't feel as though we've done enough communication with the actual patients about what this transition will entail.
Right.
How do you respond to that
Well,
particular
I think
feedback?
first of all, understanding that over the past 2 years, we really had to build the process and what the system is going to look like. And we are now at a place where we have information about what will happen that we can then communicate to people in care so that they know how to access service, that their provider will not change, that if you need support, this is where you get it, and so forth.
Mhm.
We now have those details. Change is difficult. Change is destabilizing. And I always remind our team that the change process is always difficult, but once you get to the other side, we're going to have a stronger, higher quality system. And we will be sharing direct information, both Director Byrd and I, with people in care so that they know
Okay.
what to do.
So there should be like a email or mail communication that will come out prior to April 1st, hopefully
Oh, absolutely.
February or
Oh,
March.
yeah, way before April
Okay.
1st, as well as we plan to conduct in-person meetings, in-person
So
town
that
halls.
patients can ask
So
questions.
people can actually come and ask the questions that they have.
Okay.
Which we've done in other transitions. I don't know if you remember when we totally changed 35 K Street.
Yes.
Yeah.
Okay. Is it possible once you guys have those dates scheduled that you could provide that information to the
Oh,
committee so
certainly.
we can help
Yeah. Mhm.
get the word out?
Certainly.
Are there going to be any changes to the consumer grievance process after April 1st?
So as you know, the current grievance process for DBH is regulatory. It's part of the DC municipal regulations. Those will remain. But each managed care plan has a grievance process as well. And we've heard that there's some concerns about how will I ensure the service I was getting prior to the transition, I can still maintain it. Those grievance processes are available, and that will be a part of our consumer information that we publicize and that we do in forums.
Okay, but the grievance process would be largely transitioning from OAH over to an internal process within the Medicaid MCO?
I don't believe that that is correct.
Okay.
But I'd like the opportunity to follow up in writing with the committee on what the grievance process will or will not be, any changes.
Okay, that'd be great. So once the transition happens, how does DBH envision its role for oversight and accountability of the provider network once they're incorporated to the MCOs? Or is that now going to become a responsibility of the Department of Healthcare Finance?
As a single state authority for behavioral health, And in accordance with our statutory legislation, there are some responsibilities the DBH has and will continue to have. And so we will continue, for example, to establish quality standards of care. We will continue to certify behavioral health providers. We will continue to certainly collect data that we can use for those purposes. We will also move to a greater emphasis on promotion of behavioral health education and disease prevention. We haven't, we're going to do much more around prevention and community education. Right now, if you think about the services and supports that we have offered over the past years, we've really focused on individuals with severe and persistent mental illness and substance use disorders. We will be broadening that perspective and now be responsible for providing supports for everyone from the worried well to, and we've done a lot of trauma support within communities, and we've already begun some of those things, and begin to use population-based data to determine what some of the behavioral health concerns are for the public, and then address those through education or other resources. We also will continue, as I said before, to provide the safety net services that I listed earlier, and continue our grant making and contracting process for specialized care.
Okay. What will be the strategy for providers billing for community support workers after April 1st?
It's the same as it is now.
Okay. So our understanding was that there's a meeting scheduled for July to address this new policy and the related.
Okay, it's not a meeting. Let me just be clear about what I said during our last provider meeting. And that is that one of the things, and I think you heard from one of the speakers, something, a term called there is change fatigue. I think you remember
Oh,
that
yes,
statement.
yes, yes.
Okay.
Mhm.
And so one of the things that feedback we got from providers is don't change community support in that framework right now, because that is a major service within our system. Let us settle down on some of these other changes before we begin that process.
Okay.
So in July, we will start the discussion with the providers and with the other stakeholders around what should community support consist of? How will what is the rate that needs to be applied, and so forth as we move forward? That is the beginning of a discussion and planning process. That is not the beginning of a change process.
Okay. So on April 1st, things will continue.
People build community support. It's within our nomenclature. It's
Right.
within-
And then sometime in the summer, a planning process in terms of what does a change look like?
In terms of, okay, we have community support. As a part of the rate study, what we've done is every service, we've looked at the quality of care and whether this is the best model and the most effective model based on the data, and then how much does it cost to provide this service? And so those same factors are things that we would look at for community support. What does the model look like? What does the service look like? What are the key elements of the service? What is the delivery process? Who should be delivering it? And then how much does it cost to make sure that providers can deliver the model?
Okay. So what will be what will the billing process be for agencies utilizing the services of approximately 7,000 or so unlicensed staff members who contribute to essential services?
So I believe you're referring to community support workers.
Mhm.
Is that what?
Those are they.
Yes.
Oh, okay. Community
Yeah.
supports / other.
Workers. Mhm.
Yeah. So in July 1st of last year, the Department of Behavioral Health added regulations to require unlicensed staff to obtain an NPI number, a National Provider Identification Number. This number will be included on claims for services. As a part of the transition, that still has to happen. So that's how unlicensed workers will be able to deliver service, and we can track that their service. That's what we're doing right now. As we mentioned, we're going to be continuously evaluating this transition with our community, with providers, and with this committee. So we'll revisit, along with the managed care plans, the best way to include unlicensed workers into billing above and beyond the MPI requirement. So I want to go on the record again saying this transition is not leaving community support or unlicensed workers out. We understand, and as you all know, it's a bulk of the service delivery model, and it's important. So I'll leave it at that.
Okay.
Right.
All right. The conversation about unlicensed versus licensed made me think of another bill that we have on scope of practices. So we have the health occupation revision bill. You know, DC Health was the main agency on that because they have the boards and commissions, but they are recommending some changes of scopes of practices and otherwise in the behavioral health wheelhouse and realm of things. And can I just ask Dr. Brazaran that someone on your team take a look at some of the changes, and if you all
Certainly.
have some particular feedback, especially as it pertains to psychologists and some others, that you're able to speak to that. Separately, there's a different bill that we have been having, Councilmember Robert White introduced around changes in licensing requirements for social workers, which would allow for them to do more without having to take the exam. And we would love some feedback from you on that. There were actually a number of DBH staff who on their own time provided testimony on that particular bill. But if again, that was another one where DC Health was the center agency on sort of responding. But again, the social work component, especially as a lot of the conversation was around mental health and case management, I think falls in your wheelhouse. And I want to make sure that you all have an opportunity to respond before we take action on any of those two pieces of legislation. Okay. I want to go back to talking a little bit about young people in terms of the prevention centers. So in FY23, based on the pre-hearing responses that you all provided, the DC Prevention Center served nearly 2,200 fewer youth than they did in FY22. And I want to ask, what are some factors that contributed to that reduction in clients served? And what's our plan for reversing this trend?
I think, as you know, too, sometimes the numbers are duplicative. Sorry. Make sure.
You can
it's
pull it
close.
closer to you too.
Just so those numbers, again, it could be potentially some of the same youth attending the same different events. And so it's not necessarily unduplicated data. What was the other piece of your question?
How do we plan to improve for FY24 to
Sure, of
reverse the
course.
trend?
So I think all of as we are obviously returning back into in-person events, our prevention centers are reaching out and doing in-person events, as well as they've been working with our school-based clinicians, as well as partnering with DCPS and other schools to try to provide additional support and services. So I think trying to broaden the lens of how we are using the prevention centers now that we're out of COVID and back in person. And I think tapping into some of our other sister agencies and working with CFSA, DYRS, and other opportunities that maybe we didn't necessarily tap into during COVID.
Okay. To what extent does the staff of the DC Prevention Centers engage at all with Clear the Streets or other violence interrupters, particularly in the communities for which they are housed?
Yeah, I mean, that does happen. I think that we encourage, obviously, to be out doing outreach out in the streets. So I think that's something that we encourage and are interested in increasing.
Okay, is a DC Prevention Center an appropriate place if a parent has a concern about a young person? Potential substance abuse use?
Of course, they can provide resources. And if there are specific, if they're looking for treatment options, they can obviously refer them to our, either the A-step providers or other, hopefully, once we have our residential facility
Mhm.
in the district there as well.
I wanted to ask a follow-up about that. I think you told Councilmember Parker that the RFP, or maybe it was Councilmember Nanette, I'll say one of my colleagues, that the RFP was for DC or within 50-mile radius. Can you talk a little bit about the reasoning for the 50-mile radius piece?
We obviously want to have a facility in DC, but at the same time, it's important for us to make sure that we have this level of care and services. And so we broadened the range a bit to potentially include other jurisdictions within
Okay.
radius.
By including other jurisdictions, would that allow a provider to not only accept DC patients, but also say a patient from Maryland if they were there?
Our focus is DC.
Yeah, and our focus, and it's also, I think, written, I don't have it in front of me, but it's preferable to DC. So within, again, as we talked about the evaluation criteria, obviously, we would prefer for it to be in DC, but again, that's, the specific, we didn't want to limit ourselves so that we didn't get anything.
But however, I think your question is this for DC youth or is it for other youth? This is for DC youth.
Right.
No, I understand.
Yeah.
What I was saying is, I think in another conversation I had with someone, they talked about centers liking to sometimes house their operations on the borders, right? So they can get if they are in Maryland or in PG or whatever, they're getting a bunch of folks from Maryland because their population is larger. So they're able to sustain efforts. But then they also know that it's not that far from DC for us to cross the line. So therefore, they get to maximize in terms of serving both, patients from both jurisdictions. That's what I'm trying to understand, is our hope and desire that would only be for DC folks. It
Yes,
just happens
that's
to
correct.
be.
Yes.
That's correct.
Yes.
Okay, all right. Just want to make sure on that front. Okay, Dr. Bazaran, I know Councilmember Parker asked some questions about school-based mental health, but I just want to follow up on one thing in particular. We had an LEA who testified yesterday. They've been waiting for 2 years for a clinician. And my understanding is that you all had have a pilot program such that if a school was not paired with someone, they have an opportunity to do something different.
Right.
That's launched, yes?
Yes.
Okay, and has this particular LEA been made aware that this is available to them?
We have spoken ad nauseum at our school-based behavioral health council meetings. We have worked with the charter board. We've worked with DCPS. We've worked with all of our partners. And we have actually advertised the RFPs multiple times.
Has
to
anyone
continue.
taken you guys up on the offer?
Yes, she can give you the
Yes,
data.
so
Yes.
10 applicants, 10 applications were submitted. And we just made the grant awards. 5 schools will be receiving the funds directly.
Okay, and so is that for 1 year? So, or will that carry them into next school
There's an
year?
option year.
Okay,
Mhm.
all right. Offline, could you follow up and tell us the 5?
Yeah, we have the names.
I do school visits, so it's good to just sort of have an idea in advance going in of
Right.
who.
And one of the things, council member, I think I've shared this before, and that was that, we have had to put these solicitations out multiple times and have had to really work hard to get people to apply, even though we were responding to their requests.
Their requests, yes. But
I mean, so.
I do think though, for some of the single site LEAs, in their minds, they're like, well, just give it to me, I can do it. But then it gets daunting. The difference being a multi-site LEA who has more staff, more resources, et cetera, this might be something they more desire, right? So I would be interested to see what schools applied
Uh-huh.
as a sort of gauge, because they were, particularly on the charter school side, they were coming at me with, well, just give us the money and we'll figure it out. And so you've done what we asked,
That's right.
or you've made available what they have asked for.
Mhm.
And so I just kind of want to see what the follow through piece.
Yeah, well, I can say as a former chair of a charter school board, we would jump at it.
Interesting. Okay. All right. Okay. So leaning in terms of young people, again, sorry, you're still with us. The pre-hearing responses indicated that DBH plans to create a strategic plan for children's behavioral health that will be completed by the end of FY '25.
Mhm.
Why is this going to take until October of 2025 to complete?
Because of the input process, and we want to make sure we have, like when we did this once before, we had a significant number of opportunities for members of the community to give input. And then we could analyze that input and use that as a part of our plan. We put ideas out there again, get feedback again. It's iterative so that we have the appropriate strategy in place. And I'll turn it to Dr.
Wait, I'm actually getting
Sullivan.
my dates confused. If it's the end of FY 2025, that means it won't be released until 2026. Was that a typo, or is that the accurate timeline?
That's accurate. I think that when we, as Dr. Bazaran mentioned before, when we did it before, it was about a year of planning to get the input across sister agencies as well as advocates, parents, families, and then to actually produce the actual document.
Okay. In terms of there is an existing strategic plan, yes, that we've been working through.
Mhm.
Have you all developed or ever released, I guess, your own report card on how well you've done with the plan that we already have in place?
Not that I'm aware of.
No.
Okay. Is it possible that you could provide us a copy of the existing strategic plan? I think it's, before we go trotting a new course, we probably should check to see, did we do what we said we were going to do in the current one? Or if there's anything on the current plan that's still worth continuing.
At this point, it's very dated. It was developed quite a while ago.
Oh, when was it developed?
I don't remember the date,
I
but it
believe
was.
it's 2012. Or at
2012.
least
Oh,
that was
okay, so it's
12.
about a decade.
Mhm.
All right,
So it's a long, that's what I'm saying.
okay.
We were in a very different place then.
Oh, yeah, for sure. Especially as we think about what's happening with young people now, pre or
Mhm.
post pandemic,
Mhm.
otherwise, but that's a long time. It sort of reminds me of when we had DCPS. It took them 50 years to redo school boundary lines, and then it was a painful situation for everyone involved. And even though everybody's mad at me now, I'm forcing them to do it every 10 years so we don't go a 50-year
Mhm.
mark in order before we do it again. Okay. I'm just checking my notes here. I think we might be at the end for, right now. Okay, we're not. I'm going to end on PIW. You and I have had lots of conversations about PIW. I've met with the new leadership team at PIW.
Mhm.
And yet we're still hearing some concerns about yep, no, I see it. Yep. We're still hearing some concerns around patient safety and some other things at PIW. Can you talk a little bit about the not just your level of communication, but in terms of your staff going over to the actual facility and observing and the
Certainly.
frequency with which that's happening?
Yes, certainly. First of all, under Dr. Moise, his team of his intensive care coordination team is very active at PIW, and Jana Burhow actually manages that particular contract. They conduct concurrent reviews of all of the admissions to the facility twice a week. for each person that's submitted to ensure that there's clinical efficacy and that they're meeting the monthly requirements. We also do a monthly on-site visit to PIW to ensure here again that things are going as they should. We also do a random selection of records and review them. We pull those records to see what's happening, and we also observe the clinical practice to get some, to be able to give them feedback on clinical practice. The one thing that we should mention is that our contract doesn't cover adult voluntary or child and youth admissions. It's
Okay.
very specific. However, one of the things that I think you're aware of is that DC Health and DBH work collaboratively to provide oversight. DC Health actually holds the contract.
Mhm.
I am having monthly meetings with the CEO, the newly appointed CEO,
Yep.
to address some of these issues. And so we know there's a lot of work to be done, and we certainly are aware of that.
Okay. In terms of the not having children and youth under the contract, what was the specific reasoning behind that?
This is for the FD12 contracts.
Okay, FT12 contracts. Okay. Is there, in your conversations with PIW, I'm gonna ask on behalf of DYRS, that you help what do you call it, mend the relationship, where I have a DORS director who says PIW doesn't often want to take their youth. And given that we don't have very many places that have emergency treatment for young people, that creates a bit of a challenge for them and their team at YSC and New Beginnings. And so however we can help
Mhm,
bridge that relationship
mhm.
as we work on these other pieces, I think that is super important, because I think, you and Dr. Bennett could be very helpful in helping to communicate some things on behalf of Director Bede.
Mhm. And as you know,
bet.
we have worked together with DYRS around the needs for admission to PIW, and we will continue to do that.
Okay, great. One other thing that has been raised in terms of the inpatient psychiatric facilities is at St. Elizabeth's. So we had testimony on Monday from a nurse consultant who represents the hospital, the Nurses Association. And they highlighted some safety concerns that they've heard from their members around some of the staffing conditions and otherwise at St. Elizabeth's. This includes, nurses being subject to attacks by patients, it's a challenging environment altogether. But I'm curious what specific measures or strategies you all are employing to both get feedback from the staff at St. Elizabeth's, and then also address some of the new things that they've raised.
Are you saying at St. Elizabeth or PIW?
St. Elizabeth's.
Oh, at St. Elizabeth, then our CEO is here, and certainly he has ongoing meetings with staff, which are specifically designed to gather their input, and has created structures so that he can collect that information, he can report on those. And so, Mr. Chastain.
Yes. So we,
You just turned it off. It was, go ahead.
I'm sorry, yeah, we address the issue on an ongoing basis. We have a committee, a shared governance committee, which represents labor and management, and we come together at least monthly to talk about how we can improve safety. It's an ongoing challenge. We address it from a facility standpoint, from a staffing standpoint, from a training standpoint. Continuous improvement in all the three of those domains. And so we've increased and improved staffing, added security staffing as an example. We've improved facilities. We've created barriers where aggressive patients can't hurt staff. And we have ongoing training programs. Excuse me.
Okay.
And the
And
other-
I
Three
saw
of
some
them.
of that in place when I came in and did a
You saw
tour.
it, yes.
Uh,
But one of the things also I'd like to say is we are using the technical assistance training and support from a national trauma expert, Dr. Joan Galise, and she is working to really provide training on trauma-informed care and infuse trauma-informed care practices that are designed to decrease any kind of outbreaks and also address the kind of issue that you're talking about. There's a TAMAR curriculum that's being utilized with both staff as well as people who are in care. And the whole goal is to change the environment and to make it much more not only safe, but also much more of a therapeutic and trauma-informed process.
Okay. We also received information about the necessity for a new blood glucose monitoring system for St. Elizabeth's Hospital.
Yes.
But staff reporting that the management or that you all have deemed it as too expensive. You want to respond
So
on
we've
that?
addressed that in two ways. Short term, we've got new glucose monitors in place. And we're putting in a comprehensive new system, blood glucose monitoring system. It involves some technical changes, both software and hardware,
Okay.
and that's in process.
Okay.
But in the short term, we've replaced the monitors to make sure the patients are getting good care and good monitoring around glucose management.
All right. That's what I like to hear.
And again, we address all of these issues you're referring to comprehensively in monthly meetings with labor and management. We have a written plan. We're happy to provide it to you. That provides both what we've done in the past, what we're working on currently, and what we're planning in the future. We have a comprehensive plan to address this issue.
Okay. Thank you. Dr. Bowser, I want to follow up on, I think Councilmember Parker was asking about the mayor's emergency opioid response. Something very specific that was outlined for as it really pertains to opioids, which was the data sharing amongst the various agencies.
Mhm.
And I want to give you an opportunity to provide a status update on if that work was actually done in terms of you all sharing more information in real time.
There is a cross-agency group that represents the various agencies that's been working actually since that came up to look at what questions are we trying to answer with the data? What systems do we need to support that? What data elements do we need to collect? And so that is moving forward and is in process.
Okay. Is there going to be a outward facing data reporting structure where people can sort of follow along in terms of?
My understanding, and I don't want to, and I'll follow up specifically with members of the committee, but my understanding is that this is an internal data sharing activity across all of the various departments.
Okay. Give me just a second. Okay. All right. Well, that concludes the end of my questioning. We do have several follow-up questions that we'll send to Malcolm and your team. If you could get those back to us in a timely fashion, that would be great. I want to thank you for providing your testimony and information to the committee, and then also for making your team available to answer questions. Like I said, if we have any follow-ups, we'll certainly reach out. Although this hearing was for the Department of Behavioral Health government witnesses, if anyone would like to submit testimony for the record, but they weren't able to do so on Monday, the record for the Department of Behavioral Health will remain open until 5 p.m. on Wednesday, February 14th. Oh, what a Valentine's Day. Okay. You could submit your testimony on the council's hearing management system. If you go to dccouncil.gov/hearings and just click on this particular hearing, you can upload your testimony right there. Our next performance oversight hearing for the Committee on Health will be a joint hearing between the Committee on Health and the Committee on Hospital and Health Equity for the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance. That will be on Thursday, February 8th at 9:30. The time is now 12:55 and this hearing is adjourned. Thank you.
Okay.